estás?
Muy bien, yo es. Muy bien, yo es. Voy a colgar.
We're all set.
Andrea was. Okay. Good morning, Ray.
Good morning.
We are on time. Estás?
Muy bien, yo es. Muy bien, yo es. Voy a colgar.
We're all set.
Andrea was. Okay. Good morning, Ray.
Good morning.
We are on time. Good morning, everyone. Welcome again to the second day to this Hirschsprung course. We hope that you enjoy this meeting as we are enjoying to have more than 3,000 participants yesterday. Thank you very much to stay with us. I hope you learn as we are learning with you, with your questions. The most important question came from you, so please type in the chat any question. There is no stupid question. All questions are very important. So the first conference is total colonic aganglionosis, which I personally consider a different disease. This is not a Hirschsprung, the classic Hirschsprung. Good morning, everyone. This problem is a different approach, completely different approach and treatment and follow-up. So I'm very happy that Andrea Bishop, which is the program director of our International Center of Rectal and Genital Care, is going to present this conference. Thank you very much, Andrea. Participants. Thank you very much for staying with us. I hope you learn as we are learning with you.
Good morning, everyone. We're now going to talk about diagnosis, when and how to do it.
There is no question.
So first, we're going to discuss two scenarios. The first, the ideal scenario, when you suspected total colonic aganglionosis based on the fact that the patient did not respond very well to rectal irrigation, or the contrast enema did not show a clear transition zone. So in that case, you decided to do leveling colonic biopsies and you open an ileostomy. The second scenario, not so ideal, you did not suspect or you thought this was a case of a rectal sigmoid heat, decided to operate on the patient during the newborn period. You started transanal, and to your surprise, as you get intraoperative biopsies, they all came aganglionotic. So we hope that if you were in the second scenario, you work with very good pathologists that knows how to do the intraoperative diagnosis with frozen section, because the worst thing that could occur to a surgeon is removing the entire colon and then finding out on permanent section that this patient had ganglion cells in the colon. So in a way to prevent that, I think in most cases, since it's such a big difference for the patient to be without the colon or with a piece of colon, we want to be 100% sure. We want to be more conservative. So you probably want to have permanent sections, knowing before you do a total colectomy. But let's suppose you have very good pathologists. It was a surprising case, but the patient is doing well. So you complete, you do a colectomy, you do an ileoanal anastomosis, and then you do a protective ileostomy. So the question will be when to close the ileostomy. Our protocol is we only close the ileostomy when the patient is toilet trained for urine and the patient accepts rectal irrigation. The family has to demonstrate to us in clinic that the patient accepts rectal irrigation without fighting. The reason is the longer the segment, the higher the chance of enterocolitis, the higher the chance for needing rectal irrigation. Why don't we recommend an ileoanal pull-through in a baby? We have to remember all babies are fecally incontinent. Even when they have normal anus, normal sphincter, they pass stool and urine in the diaper, they don't have control. Now, if we imagine that we are taking the colon completely and connecting the ileum to the anal canal, the small bowel has a fast motility. So this patient, under the best circumstances, when the anal canal is intact, this patient will have a lot of bowel movements and a terrible diaper rash that it's going to be very hard to manage. That's why we don't recommend an ileoanal pull-through in a baby. The baby does not mind having ileostomy, provided you have a very well done ileostomy. Babies grow fine with it, they adapt really well, and provided you explain to the parents your philosophy behind, they will understand. What happens is, in many cases, the surgeon does the ileoanal pull-through, and then the surgeon leaves the patient with the nurse, with the GI, and the mother and the child are the ones suffering. One of the problems of ileostomy, or maybe the most common problems of ileostomy, is prolapse. And we have to think, why do they happen and how we can avoid it? So I'm going to show a diagram. This is a diagram of the colon, and it also explains why colostomies prolapse. And then you will understand why ileostomy prolapse. So when we are looking at this diagram, if you want to open a left transverse colostomy, you always have to think the portions of the bowel that are mobile and the portions of the bowel that have attachments to the abdominal wall or are fixed. So the portions that are fixed are the ones that will not prolapse. But in this case, because the transverse colon is mobile, the proximal stoma is the one that will prolapse. Now, if we want to do a right transverse colostomy, here in this case, the distal stoma will be the one that is going to prolapse because it's in a mobile portion in the transverse. And this one will not prolapse because it's close to a fixed portion of the colon. Now, the colostomy that we recommend for anorectal malformation, the descending divided colostomy, the descending, the proximal, will not prolapse because it's close to a fixed portion of the bowel. And it's the mucus fistula that has the tendency to prolapse because it's in the sigmoid that it's a non-fixed portion of the colon. So if we are doing an ileostomy, there is no fixation. So they will always have a tendency to prolapse. because we are creating an ileostomy that it's going to be with the patient for a long time, I like to fix the stoma into the abdominal wall in an attempt to avoid prolapse. But sometimes we didn't do the ileostomy and the patient comes to us with a prolapsed stoma. It's important to remember in patients with colorectal conditions, we don't want to resect bowel because the bowel is very important for them. So if a patient comes with a prolapse, try not to resect bowel. What we do is we pass packing gauze, so you can see here with betadine. And as we are inserting into the stoma, we are reducing this prolapse. And we insert generous amounts of packing gauze. Then we're gonna palpate the abdomen and see where we can find that sausage, the packing gauze that we just inserted. So here you can see in a drawing where we palpated. So we don't touch the stoma when we repair prolapse. What we do is once you palpate where the bowel naturally went with the packing gauze, then you're gonna open an incision away from your stoma. You open skin, subcutaneous, anterior fascia, muscle, posterior fascia. You identify the bowel. And then you're gonna close the aponeurosis and you're gonna grab a piece of the bowel wall so you can tag that abdominal, that intestine, that ileum to the abdominal wall, and that way avoid prolapse. So that's how we fix our prolapse. Again, a lot of packing gauze, then you feel the sausage, then you open, and as you start to close the abdominal wall, you're gonna grab a piece of the bowel, so that bowel will stay in place and no longer prolapse. Now, patients with ileostomy, they lose a lot of salt. So what we do is we measure the urinary sodium. If the urinary sodium is below 20, then we're gonna start oral supplementation. We use 1 mg per kilo every 12 hours. And then after 1 month, you're gonna check the urinary sodium again. If it's still below 20, then you can go to 2 mg per kilo every 12 hours. But usually patients correct well, and this allows them to grow properly. So in a patient with total colonic aganglionosis, a damaged anal canal means a permanent stoma. This is a very important statement. So I know during this course, you're gonna hear a lot the importance of preserving the anal canal, because that's where the sensation is, that's where bowel control will happen in patients with Hirschsprung. Now, if we have a patient with a short segment Hirschsprung, rectosigmoid, that the anal canal was damaged, we can offer bowel management. We can find out an enema recipe that given once a day will keep that patient artificially clean for stool. Now, when we have a patient with total colonic aganglionosis, if the patient has a damaged anal canal, there is no bowel management. We don't do enemas in the small bowel. Enemas are for the colon, not for the small bowel. The small bowel is to absorb nutrients. The small bowel has fast motility, so there is no bowel management for small bowel. So if the anal canal is destroyed in a patient with total colonic aganglionosis, all you can offer is a permanent ileostomy. So we have to be careful in every surgery that we do. Total colonic aganglionosis, you have to be even more obsessive about preserving the anal canal. So this is the worst diaper rash we have seen in our life. This was a patient with total colonic aganglionosis in which the anal canal was completely damaged. So the patient had a perineal ileostomy. The patient was constantly passing stool, and as you can see, this patient could not even sit because of severe pain. So this patient, the only treatment we could offer was an ileostomy. So this is a very sad case, and it's preventable. So hopefully in the course, you will leave with this message about the importance of preserving the anal canal for all patients with Hirschsprung disease. So let's suppose that you receive an email of an anxious mother saying that her 2-month-old daughter received the diagnosis of total colonic aganglionosis. She underwent an ileostomy at the umbilicus, and the surgeon is planning for a pull-through in 6 months. Now the mom wants to know your opinion about the case. So before giving your opinion, you should ask the mom the following questions. How is your child? Is she growing well? Remember, if a patient has an ileostomy, we have to dose the urinary sodium. If the patient is not growing well, one possibility is that the patient needs oral sodium supplementation. Second question, is the defunctionalized colon still inside? So some patients, they stay with the colon and they have absolutely no symptoms. Other patients, they develop enterocolitis because of the colon. So you have to think about that, because some patients benefit from doing a colectomy, even if we're going to still leave the ileostomy intact. Are you seeing any signs of enterocolitis? Do you know how to do rectal irrigations? And the other question that is missing, are you having any problems with the ileostomy? Is the ileostomy prolapsed? So this was the picture of the ileostomy in the umbilicus. I know many of you have heard of this idea of trying to do a stoma in the umbilicus, thinking that you will avoid a scar. Sometimes good ideas don't work, and I will say this is one that, in my opinion, doesn't work, especially for an ileostomy. So as you can see, her umbilicus was destroyed. Her skin around is very irritated. This is very painful and uncomfortable for the baby. So the first thing we had to offer was an ileostomy revision to let the umbilicus heal. So we did the ileostomy revision. Even when it all healed, you can see that the aspect does not look perfect. So this is the reason why I am not a fan of doing stomas in the umbilicus. So the ileostomy was revised. The mother was taught how to do rectal irrigations, and the patient is now growing and eating well without any complaints. Now, when would you recommend the ilioanal pull-through? And if you are paying attention, you remember that only when the patient meets criteria, she is toilet trained for urine, and she accepts rectal irrigation. Why is it so important to be toilet trained for urine? Because the patient will have several bowel movements, but if they know how to make it to the toilet, they will have the bowel movements, provided you do the surgery correctly, in the toilet, and there will be no diaper rash. Now, if you're doing a patient that is not toilet trained, they will have several bowel movements in the diaper, terrible diaper rash, even when the surgery is done correct. So that's why we only do ilioanal pull-through when the patient meets this criteria. So I can say never before 3 years of age. I know in medicine we should not never say never or always, because there are exceptions, but the criteria is toilet trained for urine, accepting rectal irrigations. So this patient underwent transanal and laparotomy, always preserving the anal canal. and we removed the entire colon and we did an ilioanal pull-through. We believe that the best type of surgery is the straight ilioanal pull-through. So here is the segment of ileum that we brought down. You can see good blood supply. You can see that the anal canal is hidden within the hooks, but it was preserved. And here's the final anastomosis. So this patient is now 9 years old. She has 6 voluntary bowel movements per day. She always had voluntary bowel movements, but I cannot say that patients with total colonic aganglionosis, we cannot abandon them. And the reason is, even when you have an excellent outcome like this one, if you follow the patient, you will see that the ileum gets distended. We are forcing the small bowel to take a role that he was not supposed to. The small bowel is not made for stasis, it's not made to hold stool. But if the patient has a normal anal canal, has bowel control, the ileum will have to hold some stool, and that sometimes generates problem. The most common that we see is dilation of the ileum, and sometimes we see irritation of this mucosa, so we have to follow these patients. So this girl, she's doing extremely well, but when we did an upper GI with small bowel follow through all the way, you can see that her ileum is very dilated. It almost looks like she has a colon, but I can guarantee you she doesn't. This is all ileum. So these patients must be followed the same way as any other colorectal patient. This was another case, a 3 days old male patient. He was discharged from the hospital that he was born, and then he came to our hospital due to bilious emesis and abdominal distension. So this was the abdominal X-ray on presentation, and you can see it's very suspicious for a distal bowel obstruction. When we did the contrast enema, you can see that the contrast enema is not as characteristic as contrast enemas for a rectal sigmoid. But with this contrast enema, I would say this is equivocal, and you should suspect that you're dealing with a long segment Hirschsprung if your biopsy came positive for Hirschsprung, meaning no ganglion cells, hypertrophic nerves. So that's the case that the best way would be to go into the abdomen, leveling biopsies, then you will confirm that this is a total colonic aganglionosis or a very long segment, and do an ileostomy. So he underwent leveling biopsies and ileostomy, and currently growing well, no problems, taking oral supplementation, and just waiting to meet the criteria for an ilioanal pull-through. So there are other type of surgeries for total colonic aganglionosis. Those are patch and pouch. So the Kimura, the Leston Martin, the Duhamel, or the J pouch. The idea behind all those patches and pouches is that it will absorb water, form solid stool, and decrease number of bowel movements. But as I just mentioned earlier in this talk, not all good ideas work. So what we see with pouches and patches in reality is that they generate more fecal stasis, that generates bacterial proliferation, that generates inflammation and secretory diarrhea. So we don't recommend for our patients, we prefer the ilioanal pull-through. So that's what I had for a total colonic aganglionosis, and I'll be happy to answer any questions that you might have. Okay, so I took a few pictures of the questions, very good questions. So I'm gonna try to answer them. The first one was, how do you try to reduce the prolapse without surgery? So if the ileostomy is a little prolapsed, but the color of the bowel is healthy, it's a productive stoma, you don't have to do anything. But once the prolapse is too big, starts looking dusky, that's when we would recommend. So it's very rare that we just reduce and send the patient home because it will come back. So and how we do it surgically, I have already shown. The other questions is, if you fixed the prolapse stoma, do you have difficulties when you're closing the stoma because of the fixation? And when you mobilize the closure, will it be difficult? Do you ever do a terse stitch around the prolapse stoma? So we always stack the stomas that are done in a mobile portion into the abdominal wall. And the answer is no. This does not make the stoma closure harder in the future. We tack to the abdominal wall with Vicryl, so usually this is absorbable suture, and we have never seen any difficulties closing. Now, the reason why we don't put a terse stitch to make the stoma narrow, because if you make a stricture, then the proximal bowel will dilate, and this will make your future anastomosis or your future closure difficult. So we don't do that. The stoma has to be draining freely. It has to have adequate size. And there is one more question that I caught. Could you clarify, if you're diverting the stool by an ileostomy, why do you still need to do rectal irrigation? So even when the patient is diverted, the colon still produces mucus. So it's not uncommon that the family will even say that from time to time, the patient passes something that looks like stool. Remember, we're gonna keep this colon defunctionalized for 3 years. So that's why in some cases, not every case, they produce enterocolitis in this bowel that it's diverted. So, but the main reason why we recommend doing rectal irrigations is for the family and the patient to gain practice. So the patient accepts rectal irrigation without fighting. Luis, any other questions?
Yes, there is a question about if you have a patient with total colonic, Hirschsprung, and the undine course and tracheostomy, is there any change in the criteria to do the picture?
No, there is no change. I had one patient that had this syndrome, is the apnea, and had tracheostomy. It was an unfortunate case that had Hirschsprung and anorectal malformation. And for that case, what we did is when we did, it was not a total colonic. It was just a short segment Hirschsprung. So what we did, because it was anorectal malformation in Hirschsprung, when we did the pull-through, we did a Malone because we knew the patient would be incontinent. But in a case of total colonic aganglionosis, I'm gonna say, generally speaking, you wanna know how is the patient developmentally. Because if the patient has developmental problems, this will be a question of quality of life. What would be better for the family? So if the patient is not developmentally normal, then chances are the patient will not achieve bowel control, and then an ileostomy would be better for quality of life reasons.
Okay, one, it says, should we wait until urinary contact is achieved for surgical correction of long segment, and here they, I think they said near the right colon. What age would you recommend to close the stomach? In the right, when you have a long segment between the hepatic flexure and the transverse flexure.
Yes, if you only have the ascending colon, I would take an approach as conservative as total colonic aganglionosis. So I would try to close the stoma around 3 years of age when the patient is toilet trained for urine.
How do you manage peristomal hernia?
First of all, you should not have peristomal hernia. So the correct management is doing the stoma correctly to avoid that from happening. If it's causing problem, then the patient will need stoma revision and most likely relocation of the site of the stoma.
I think there is a question very interesting from the Zoom. It is in lack of TPN, I think it's TPN. Can we perform a refeeding from the proximal to the distal stoma?
You can always perform refeeding from the proximal to the distal stoma. That the indications for TPN are different. And remember that feeding the colon will not improve nutrition. The colon doesn't work for nutrition, doesn't absorb nutrients. So in different scenarios, when you have ileostomy or when you have without total colonic, a colostomy that has been there for a long time, if you do refeeding, what the study shows is that when you close the stoma, you will have less chances of diarrhea. But remember, the colon does not absorb nutrients. So the refeeding will not substitute TPN.
Okay, Nicolas Lopez, if you can redo your question, please, to understand much better the question. I don't understand the question very clear. If there is another question. If the colon is aganglionic over 50%, there is perineal, I think it's a perineal damage, even in case of transanal and the rectal puncture. And
so I'm assuming there.
And therefore, you have to do a obstruction of ileoanal anastomosis and an extensive aganglionosis, as in Duhamel-Lester-Martin modification. So I think they believe they have a 50% of the colon without ganglion cells, we have to do a Lester-Martin procedure.
Okay, we don't do Lester-Martin, we don't do Duhamel, we do straight ileoanal. Even when the entire colon is aganglionic and our patients have voluntary bowel movements. As I explained, the idea of having patches and pouches is to slow motility. But if you remember that patients with Hirschsprung, they don't tolerate stasis. So if we create mechanisms for stasis, this generates more inflammation, more secretory diarrhea, and ends up being the reverse. Of course, there are cases that have had the surgery and they are doing well. We only see the ones that are not doing well. So,
okay, there is a question about the age of the pulmonary in patients with total colonic aganglionosis. How do you know if the patient is going to have good bowel movements and fecal control when they are urinary toilet training? Because sometimes they are very young, a patient, and immature patient. So how do you know that?
So our criteria is that the patient is toilet trained, meaning that he knows how to go to the bathroom to pee. And the patient accepts rectal irrigation. So this does not happen before 3 years of age. And then on the first day of surgery, after surgery, they will travel 20 times to the bathroom, but they know how to go to the bathroom. And they toilet train just like that, because they already know the mechanism that when they feel the urge for urine, they have to go to the toilet. So they catch it right away for a stool. It's just the way we observe it works.
Yeah, and I want to clarify, this is not an ileoanal pull-through because everybody's typing in the chat like ileoanal. Please listen. Try to erase from your cerebral cortex, from your brain, is an ileorectal anastomosis. Remember, we have to use the anal canal and a small portion of rectum. So when you say ileoanal, I don't want to believe that you are doing a wrong operation. So in order to have the same communication, please try to change your mind and write always ileorectal anastomosis, because this is very confusing for many people, as I can see in the chat. The use of loperamide in patients after the ileorectal pull-through in patients with total colonic aganglionosis. If you can answer, Andrea.
Yes, you can definitely use loperamide if the patient is having. What I consider feasible is that the patient has between 4 and 6 bowel movements. More than that, it becomes difficult for them to play sports, to go to school. So if it's happening more than that, they definitely should take loperamide. How infants with ileostomy become toilet trained? They will become toilet trained for urine because their urinary system has no problems. And once that happens, and when we do the ileorectal anastomosis, then they will become toilet trained for stool tube.
Again, Andrea, there is another question in Zoom. We explained yesterday the use of how to connect. The question is how to connect the bowel into the rectum, very close to the anal canal. In short, Hirschsprung, in long segmentation, in total colonic aganglionosis. How are you do your connection, your pull-through, using Suave, Swenson, or Duhamel? We explained that it doesn't matter. If you are doing a perfect Duhamel, you can do Duhamel. If you do a Swenson, you can do Swenson. So again, the confusion, Andrea, if you can explain, please. Everybody's asking why we don't do Duhamel in total colonic. There are many questions. So I think many people believe that the Duhamel was described for, after Lester Martin, I mean, I believe that the only way to do the push-through is using a Duhamel procedure.
Okay, so I think today there are more lectures about surgical technique, but we, in all surgeries, we have the obligation to protect the anal canal. So the way we do it, we use the Lone Star retractor. We initially put the hooks at the mucocutaneous junction, then we identify the anal canal, then we advance the hooks deeper, completely protecting the anal canal. You don't see the anal canal. And then you still put your stitch 2 centimeters deep. So you're still leaving healthy bowel, we're still leaving bowel there to fully protect the anal canal. And I showed in my presentation how I did it and how at the end you can see that the anal canal is fully protected. If we want to give this patient bowel control, we must preserve the anal canal. So I only start my dissection 2 centimeters above the pectinate zone. So that is very important. The protection of the anal canal is key for this operation. The reason why we don't do patches, pouches, it's what I already explained. They were made with the good intention, with the good idea that a piece of colon would be left to absorb water and that the patient would have better formed stool. That's not what we see in real life. We see those patients that have those pouches getting inflamed, getting pouchitis, getting more enterocolitis, and we end up having to remove these pouches. So we prefer to do ileorectal anastomosis, straight anastomosis. Now, if you do Hamel and you have good results, continue doing it. We don't argue with success, but we're just explaining what we do for our cases with total colonic aganglionosis.
Okay.
There is one question that I think it's good to answer. How do you make children accept rectal irrigation? So rectal irrigations, they are not painful. So the way that's why we want our kids to get used to do it since they are babies, so they feel that this is normal for them. And what we do is we give the polycatheter to mom so they can see how it's soft. And then they practice, even if they're not getting good real irrigation, they practice inserting at the anus and the baby gets used to that. So it's not a fight when a real rectal irrigation is needed. And when patients are older, they even ask the parents, I need a rectal irrigation because they feel much better after one.
How many biopsies
Anomalous up to the cecum, and we just did a study that we're going to be publishing soon, that the appendix is actually good for the diagnosis. If you're not sure, don't remove the appendix. You can just take the tip of the appendix, the distal 1 centimeters, and then on permanent section, a good pathologist can tell you if there is ganglion cells or not. If there is no ganglion cells, this is a total colonic aganglionosis. But in all cases of Hirschsprung, you start with a rectal biopsy. That's the first step. And if you're suspecting total colonic, you need sigmoid biopsy, descending colon, transverse, ascending colon, and the tip of the appendix.
I don't know if you want to answer the last question in the chat.
The difference between total colonic aganglionosis and intestinal neuronal dysplasia. So we personally don't believe this entity of intestinal neuronal dysplasia exists. When you question pathologists about it, there is no consensus on what it is. So if you get that diagnosis, I would say get the slides and send to someone with a lot of experience, and most likely it will not be it.
Zoom.
Oh, there's one very good question, Luis. Why the anterior abdominal wall would accept an ileostomy, and in the perineum we develop dermatitis? So that's a very easy one to answer. When we do in the abdominal wall, we raise the stoma, we brook the stoma. So the content of the ileum is going directly to a bag. Now, when we do it in the anus, it's flat, and the content of the intestine is going directly into the perineum and into the skin. So that's why it doesn't tolerate.
There is another question. When you do a pull-through in total colonic aganglionosis, do you create an protective ileostomy after the pull-through?
I don't. So for most of my cases, I either do a total colectomy and ileorectal once the patient meets the criteria, and then I don't do a protective ileostomy, but I keep the patient NPO for 7 days on TPN.
Very good. So there are more questions. But we can answer with the following conferences. So, Ray, can we move forward with the next conference? The next conference is about what I consider is the two most common problems after a pull-through. When you do a pull-through, many patients have residual problems, even after a perfect pull-through. Is what I call the obstructive post-operative problem, not related with mechanical obstruction, not related with an structure. You did a perfect pull-through, and now the problem is that the patient is not passing gas, is not having bowel movement. So this problem, we have many resources, strategies, protocols. I want to explain in this conference how we do, what we do with these patients. Thank you, Ray. Go ahead.
Good morning, everyone. Good morning, everyone. Now, I want to talk about one of the most problematic situations that we already have unsolved after a very good operation for Hirschsprung disease, which is the post-operative obstruction, which is an unsolved problem in 30 to 40% of the patients. When we do a perfect pull-through, means that we mobilize to the pelvis, to the perineum, this green bowel with ganglion cells, no transitional zone, no dilated. It's a beautiful bowel. And then we do the anastomosis very close to the anal canal. And we preserve 1, 2, 3, 4 millimeters, 5 millimeters if you want, of this rectum with aganglionosis. This is a perfect pull-through. However, 30 to 40% of the patients after a perfect pull-through, they can develop what I call 2 residual diseases, 2 residual problems, colitis and constipation. This is a patient that had a pull-through, nice pull-through, perfect ganglion cells, perfect anastomosis. She was doing great at home. And 3 months after the pull-through, she presented to the emergency department with a history of 2 days with slow bowel movements, no passing gas, and a sudden event of abdominal distension and vomiting. Many years ago, these patients were treated like gastroenteritis or gastroenteritis or diarrhea, but it's not. This patient developed a severe event of inflammation of the colon with obstruction. We know it's an obstruction because most of these patients, when we took an X-ray, you will see a colon with a severe dilation. You can see enlarged and dilated, and you don't see gas in these patients. It's like a line between liquid and gas. And if you introduce something here, like a rectal tube, just 2 or 3 centimeters, you can obtain all this gas and the patient is going to improve. So something happened in this critical area of the patient. This is what happens when a patient after a puncture, a perfect operation, start to have abdominal distension, diarrhea, fever, and the parents try to help. They have explosive bowel movements and this kind of stool. So let's review what is our hypothesis about this process. We believe that when you do a puncture, this is a Swenson puncture, so we don't have the bias of the pouch of the Duhamel, you don't have the distraction of the muscular cuff in the suave patient. So in this Swenson puncture, it's beautiful. The bowel with a lot of ganglion cells, no issue. A perfect anastomosis. You can leave 1 to 3 millimeters of aganglionic rectum right here and the anal canal. But all this red area is sick, and I call the residual Hirschsprung that we must have to leave in this patient, because if you do the anastomosis down here in this level, you are not going to have problems of obstruction. So the patient never will have colitis of constipation, but the patient is going to have severe fecal incontinence because you reset the natural reservoir, which is the rectum and the sigmoid. So these patients without reservoir, okay, when you connect these segments to very low to the anal canal, these patients suffer fecal incontinence because this is the most sensitive area in the human, and allow the patient to feel something and have fecal control when they born with Hirschsprung. If you preserve this sensation, the patient will have fecal control. But this red area is the problem. So this small amount of tissue in patient with Hirschsprung produce a high pressure zone. So you can cut here in this line, and you are leaving here probably 5 millimeters, and this is all the dented area from here to here, the anoderm, and the skin. So you cut, and the anastomosis is going to be here. So we are leaving just this very small amount of aganglionic rectum, even though many patients, 60 to 70% of the patients, have no problems when you leave this very small amount of aganglionic rectum. If this line is down here, then the consequence is fecal incontinence and no obstruction. So you need to decide. So the green area versus the red area is what I call the fight between two different segments. If this portion was dilated for many, many days, many months or years, or you don't do a very good irrigation in an event of colitis and you left the patient to have chronic dilation, more dilated colon, less motility. More dilated colon, more problems to resolve this issue. So this is the force of the puncture versus the force against the colon, the force from this area. Imagine that this area, just like an example, produced a pressure of 100, and this only produced 90. Who is the winner? This area, and the patient is not passing gas or stool, is not pooping, is not having bowel movement, and produce severe or problems with constipation or colitis if the patient has other symptoms. So in this illustration, you can imagine how we can explain this situation. So when the colon becomes with obstruction, that's why we call obstructive, and then inflammation and proliferation of bacteria, that's why we call this the obstructive proliferative colitis. It's not the enterocolitis that we see in the prematures where the small bowel is also affected. Many years ago, in patients with colitis, when we took him to the OR for a colostomy, we never found a necrosis or ischemic lesions in the small bowel. Instead, we found a very dilated colon in these patients before we start to do irrigation. I'm talking about probably 90, 91, 90, 87, when we did a pull-through and the patients came back to the ED with this obstruction, we took the patients to the OR to produce a colostomy and create a colostomy. And we never found the findings of the common enterocolitis. So the residual colon needs to push against the anal canal. So who is the winner? If the colon is having good motility and produce more pressure than the residual anal canal, the patient is going to have normal bowel movement. However, if the anal canal and the residual rectum produce more pressure than the colon that we use for the pull-through, then the patient is going to have obstructive symptoms. And you will see this type of colon. This is because in this very short area, there is more pressure than the pressure that can produce the colon that we use for the pull-through. Look this video. This video, you can see in the descending colon, the left colon that was used, this patient doesn't have sigmoid, how you can see the contraction. Look, this is a huge contraction, but the contrast is going back, is not propulsive, is not going forward. There is another huge contraction here, but it's not enough to have a bowel movement. You don't see nothing at the bottom of this study. The patient is not having bowel movement. So you see how it's squeezing again now in the lateral view. This patient has good ganglion cells in the pull-through, no structure. It was a Swenson pull-through. The patient was operated primarily without colitis. The patient was doing well, and 6 months later, the patient started to have obstruction. So this is a very illustrative image that you can see. This is a static X-ray, so you can see a huge contraction. This is the shape of the mucosa of the colon with inflammation. This patient is suffering severe colitis, and you can see this obstruction now produce this dilation on the right side. So before starting medical treatment for the residual obstructive disease, the surgeon needs to assume that the patient has a mechanical obstruction. So we need to rule out mechanical obstruction. Or we need to assume that the patient had a aganglionic pull-through. So we need to rule out these two possible problems. One is the mechanical obstruction, and number two is the residual aganglionosis. In order to do that, you must perform an exam under anesthesia. During this study, you need to identify the line of the colorectal anastomosis. And this is very clear because the mucosa of the rectum
is different from the mucosa of the colon. So you can determine where the line of the anastomosis was performed. You need to exclude any structure of the anastomosis. You need to do a digital exam. You need to use the Hegar dilator. You need to be sure that there is no structure, there is no fibrotic rings that cause this obstruction. You need to evaluate the anatomy of the anal canal. And the anal canal should be preserved in all the circumference. And then you need to take the biopsy of the neo-rectum, not take the biopsy below the line of the anastomosis, because this is going to be aganglionosis. Then you need to perform a contrast enema. And finally, you need to go back and review the histopathological specimen of the puncture, the proximal margin when you did the puncture, to be sure that you did not perform an aganglionic puncture. So under anesthesia, you need to review this area. So you can see here very clear the skin, okay? This transition between skin and mucosa, this is mucosa. This is the anoderm, and these are the columns all the way, you can see here, more clear, of the anal canal. And the anastomosis was done right here. So this patient suffered constipation or colitis that has a very good pull-through. So you need to take the biopsy very proximal to avoid to take a biopsy from the residual rectum. In this diagram, I want to explain where you must take the biopsy. This purple area, this is the anal canal right here. This is the residual rectum. It's exaggerated just for animation. So this could be 2 millimeters or 1 centimeter. This is the anastomosis. So the biopsy to confirm that this patient did not have an aganglionic puncture should be performed in this portion of the colon. And we call this the biopsy of the neo-rectum, because it's not the rectum, it's the colon that was used for the puncture. So this is very, very important. And then the contrast enema. Usually we do the contrast enema and we try and we ask the patient to have a bowel movement. Remember, when you have a patient with obstructive symptoms and you don't find mechanical obstruction, after the contrast enema, you, the surgeon, need to be present in the fluoroscopy room to do irrigations after this study, because sometimes we send the patient to radiology, we schedule the contrast enema, and the contrast enema stays for many, many days. So this patient needs to have a very good irrigation after. And this is the most common image of the contrast enema in a patient with functional obstruction. So what we need to do? Well, we have to do medical treatment. There is no surgical treatment for this patient. Unfortunately, we don't have any operation yet to treat and cure this functional obstruction. So the medical treatment of the residual obstructive disease after a successful puncture for Hirschsprung is what you most need to practice in this patient. The most important in this patient is the irrigation. That's why we teach the parents to do irrigations before the puncture. You can see here a patient with obstructive symptoms. This is the catheter, and immediately all the gas was released.
and you need to do the irrigation. Later, Julie is going to explain you very clear how to do irrigation. We are not going to explain in this part of the course. Later, Julie is going to explain how to do irrigation in patients with Hirschsprung. In this short video, I'm just going to show you very fast what you need. Saline, folate, syringe, and then lubricant. You need to warm the saline, and then you need to introduce the catheter and allow the gas and the poop to come out. And then you need to start to do, to inject 20, 30, 40 cc's of saline. And then once you inject the saline, you need to allow the solution to come out. You need to repeat this until you obtain clear return. Once you obtain clear return, the irrigation is done. Also, this patient needs antibiotics. We use flagyl, metronidazole, 10 milligrams per kilo every 8 hours for 10 days. Don't forget, this is very important. So if the patient is at home and has symptoms of obstruction, the parents start to do the irrigation and then call and bring to the hospital. Because sometimes minutes are very important and makes the difference between a very sick child versus a stable patient. If the patient needs to be admitted because the obstruction is severe and the patient has fever, is not tolerating feeding, they need to have NPO, IV fluid, the antibiotics, and we do the rectal irrigation in the hospital. Then when the patient is completely very well, I mean, with no colitis, he's doing very well with the irrigation, we start to use laxatives. What we want to produce is very good contractions of the colon, very good contractions of the colon. We don't want to produce loose liquid. We want to stimulate the colon. So we don't use fiber, we don't use docusate, we don't use PEG. Please don't use this type of laxatives. We use Senna, because Senna is the only one that is going to help this patient. And it's trial and error, like a patient with constipation. And we're going to talk later about this, how we do the treatment with Senna. So don't forget, don't use these in patients with colitis to produce bowel movement. So we guesstimate how much we need to give. Probably we said, give 30 milligrams, okay? If we give the Senna and the patient has good bowel movement, the X-ray is clean, good. That's the adequate amount. If we produce diarrhea, we go to 3. If we produce a good bowel movement and the X-ray is clean, we keep the 4. If it's inadequate, oh, pay attention. We do irrigation, no enemas. Again, no enemas. We do irrigation in this patient and increase the amount of Senna to another tablet, square, or milliliter, whatever you are prescribing. And finally, the botulinum toxin, or Botox, is a substance that produces chemodenervation of the anal canal. We don't want to produce chemodenervation of the voluntary sphincter, of the external sphincter, of the parasagittal fibers, or the vertical fibers. We want to produce chemodenervation of this residual anal canal. So we use 4 to 8 units per kilo in every session. The BL came with 100 units. It's a powder, almost invisible. So you can dilute in 4 or in 8, and you will have 25 units or 12.5 units per milliliter. This is one of the botulinum toxins that we use. We use the needle number 18 gauge to obtain this powder, and we mix with the saline, and we use this 25 gauge syringe to inject the Botox. And we inject in patient less than 10 kilos, 100 units, in patient more than 10 kilos, 200 units, 25 units per quadrant. So we start here 25, 25, 25, 25. So we have already 100, and then in between another 25, and we already give the 200 units if the patient is 10 kilos in his weight. So this is how we do the Botox. This is the long start. We observe that it's complete the anal canal. Then we introduce the very fine the tuberculin. In other countries they call it tuberculin needle, and we need to introduce very superficial, like submucosal. Okay, we introduce just this length of the needle. So you need to feel with your finger that the needle is very superficial, and then you inject the amount that you need to put in per quadrant, and you can do a gentle massage to distribute this medication. This is a short video to show you how we do the Botox in patients with obstruction, with residual obstruction. Again, we want to do chemodenervation of the smooth muscle, not the skeletal muscle, okay? So these are the layers of the rectum, and the Botox needs to be here in the submucosa. So this is the syringe, the needle, the finger, and you will see how you can see here the medication. Remember, small muscle of the anal canal. Another one. Right there, finger, injection, and you see how this is like a subdermal, so this is a submucosal injection. So you need to play to treat these patients between irrigations and then Senna or Botox or both. So it's trial and error, but the gold standard are the irrigations. After Botox, you need to continue irrigation or Senna or both. Botox is not going to help the patient. It's just to allow the colon to be more effective with the laxative or with the irrigation. Again, thank you. And if you have any question about these residual obstructive symptoms, we have time for questions. Thank you very much. Thank you very much, everyone, for looking this video. There are some questions in the chat, and there you can help me with read some of them. I have one from Dr. Richard Scava. He is very active in the chat from Czech Republic. Okay, and Dr. Scava and everyone. First, we don't have a name for the residual problem. I agree with you. If you want to call this problem
as achalasia, that's perfect. If you want to change the name of this problem, it's not the name of the residual problem is not the real problem. It's how can we improve this patient? We know that if you have damage of the anal canal, if you have damage of the external sphincter, if you stretch too much the perineum and you destroy all the sphincter mechanism, the patient is going to be fecal incontinent. And the patient is not going to have this obstructive residual problem, constipation or enterocolitis. So the name, I think, is important, but the most important is how to treat, how to improve these patients. We've received many patients with a history of Botox injection. And when we do the exam under anesthesia, we found residual aganglionosis, and we found in some patients severe stenosis, severe problems in the anastomosis. So Botox is not the medication to resolve this problem. You need to rule out, you need to confirm that the patient had a very good pull-through. Good pull-through means the anastomosis is elastic, you don't have a structure. The Mega-rectum has ganglion cells in both places. So the patient did not have an aganglionic pull-through. That's why there are many papers about Botox in Hirschsprung with different results. Because in some papers, they never mention if the patient was submitted to a biopsy or an exam on anesthesia. Just they use the Botox as the primary medication for constipation. Unfortunately, many of these papers are from colleagues, non-surgical colleagues, GI gastroenterology. So the gastroenterologists, they use Botox for idiopathic constipation. And when you refer the patient after a pull-through to the GI, then most probably they are going to use Botox. They are not going to rule out a aganglionic pull-through or a complication in the anastomosis. Yes, we do dilations. I personally do dilation after a pull-through in Hirschsprung disease. There are other groups, there are other physicians, there are other colorectal surgeons, and they decide to do an exam in the clinic 1, 2, 3 weeks after, and they don't do any dilation if the anastomosis is doing well. And there are another group of surgeons that they never do an rectal dilation after a pull-through for Hirschsprung disease. My preference is to do dilation. The other question about the posterior myectomy. I don't believe if the patient had a good pull-through and you are going to do, I don't know how you do the posterior myectomy, but if you want to do a resection or just, I want to say 1, 2, 3% of all the circumference of the anal canal, this is not going to resolve the problem. Instead, probably you can create an area of more scar tissue and more problems. So we do not perform posterior myectomy, preoperative or postoperative. We do not use these procedures. Any other question, Andrea?
Yeah, there was a question about how many times can you do Botox and how many times it will still work.
Okay. So, you know, the Botox is a medication to have in one side the smooth muscle. We don't use it, we don't use the Botox in the external sphincter as the GI use. The gastroenterologists use the Botox in idiopathic constipation, and they inject the Botox in the external sphincter, in the parasagittal fibers, in the vertical fibers, in other words, outside of the rectum, external to the rectum. Okay, then Botox is a medication. Remember, to have a contraction, you need to have the nerves and the smooth muscle. So the communication between these two structures is with choline. So if you have a system that create a blockage, there is no more communication, you are not going to have this contraction. The metabolism of this toxin depends from patient to patient. The enzymatic degradation, the enzymatic destruction of this toxin is completely different from patient to patient. There are patients that the effect of the Botox lasts for 6 months, a year, 3 months. It depends from patient to patient. Yeah. Any other questions?
I think we got most of them. There's a question about, we have experience with older patients with Hirschsprung, short segment. How do you deal with persistent post-op obstruction despite adequate resection, preservation of the anal canal? Most cannot tolerate irrigations, especially teenagers and young adults in their 20s. I talked about this yesterday. It's very unusual to see enterocolitis in a teenager. We rarely see it. Enterocolitis is something that happens at toddlers, and then over time, it tends to disappear. I think it's important to rule out real causes for obstruction.
Just to answer,
Yes.
yeah, I have experience with patients, older patients, not in the United States. When I was working in Mexico, I worked in Mexico for almost 30 years. It was not uncommon to receive a patient with Hirschsprung over 2, 3, or even 5 years of age. So these chronic Hirschsprung patients, they need a different protocol for the treatment. Obviously, we need to do the resection of the aganglionosis, we need to do the pull-through, etc. For these patients, what I recommend is to do first a colostomy. I do not recommend to do primary pull-throughs. I do not recommend to do the same procedure when you have a timely diagnosis, if you have a baby with Hirschsprung disease, patient with late diagnosis, older patients, they deserve a different protocol in the treatment. Alberto, you want to comment something?
Because somebody said that the patients don't accept irrigations. Well, let me tell you from my own experience, when the family or the mother of the patient comes and says, I don't accept laxatives, I don't accept enemas, I don't accept irrigations, those 3 things are painless. There is no pain involved in the administration of enema or irrigation. So if the patient refuses to have that patient belongs to must be seen by our psychologist or psychiatrist, and I don't take that patient. So if my son needs an irrigation, I will do it. And I would not accept that idea of I don't accept irrigation. So you have to work very hard with that particular patient and with the mother. Something is wrong. Perhaps the patient has been traumatized in the past. Perhaps somebody has been doing painful irrigations, painful enemas, but those maneuvers are painless, and that's why there is no excuse for not giving them. So if a mother comes and says, I want you to take care of my son, and they put some certain conditions, then I said, I don't take care of your son. I need a patient and a mother that trusts me 100% and follow my indications.
There is another new question. It says, Dr. De La Torre, do you have patients a perfect surgical procedure with recurrence of obstructive symptoms? Yes, of course. When we use the Botox, remember, Botox is not the treatment for colitis. I think I was very clear in the video. If you want to review the video again, you can see the video again in the Intended Project web page later, probably next week, I don't know. But I was very clear. Botox is not the treatment for patients with colitis. The treatment of colitis is irrigation and flagging. An ancillary method, you have irrigation or to switch irrigation and use laxative, Senna, specifically Senna. You need to put pressure in the lower part of the intestinal tract. In other words, you need to weak the anal canal. That's why Botox is useful. If you believe that just the use of Botox is going to fix the problem, you are wrong. You are going to have many problems. We have seen this many times. The patient came with colitis, and the patient is immediately submitted to a Botox injection and then send the patient home without irrigation, without flagging. The patient starts to improve following the injection of Botox. But once the Botox, the effect of Botox is done, the patient has again another episode of enterocolitis. So Botox should be used trying to reduce the frequency of irrigation, and then to switch the irrigation for laxative. What I do is I inject Botox, I continue the irrigation, and then when I am sure that the Botox is doing good to the patient, because the patient is passing a lot of gas on his own or her own, the patient is having bowel movement between irrigation, I reduce the frequency of the irrigation and start to give the patient Senna. And now, and that is how we play with these different types of medications and irrigation. I have an 11. If you can do the questions very short as possible, because when they are very long, okay, our initial protocol with flagell and irrigation is 2 weeks. So we use 2 weeks, the irrigation and flagell. We're going to talk about this later in a conference that we call the management of colitis and irrigation. Dr. Bishop is going to explain how we use the irrigation and the flagell and the protocol about this treatment. So I don't want to answer this question because Dr. Bishop at 11:15 is going to explain this very well. How many times is needed the Botox? Sometimes patients receive 1 injection of Botox. And then we start with the Senna, and they are doing very, very well. Sometimes we do Botox every 6 months. The only patient that I have in my experience, in my list, is a patient that already had 4 injections of Botox. I don't have any patient with more than 4 injections of Botox. Probably help to answer this question. Yes, some groups, they inject Botox immediately after the pull-through. I have done this, yes, when the patient is not local. So the patient came to Colorado, probably from another country, and I do the pull-through, a primary pull-through. So I inject Botox in these patients after the pull-through, because I don't want to send the patient with the possibility to have the enterocolitis. Also, because the patients, when they came here from another country, we need to spend a lot of time to practice the irrigation. So why I don't use Botox in all my patients? Because usually all of them, the parents are experts doing irrigation. And again, Botox is not the treatment for the enterocolitis, it's irrigation. If you have a patient that lives very far away from your hospital, who is going to put the Botox in the other country or in another state, it is more easy and more effective, the use of irrigation in these patients. If the patient starts to have abdominal distension, fever, diarrhea, whatever, you don't need to use Botox. Again, you must have to use irrigation. That's why we do not use Botox. I think if you want to use Botox after a pull-through, is because you are not doing good irrigation. And Andrea is going to explain you very clear how to do irrigation. I don't want to continue with this very, very interesting part of my life is colitis. We can have a seminar about this issue, but I want to continue with the next conference. The next conference is about the anal canal in Hirschsprung, and when we use appendicectomy or neoappendicectomy in patients with Hirschsprung. And I have the pleasure to invite to my compadre, Dr. Alberto Pei.
Good morning, everybody. It's my pleasure again to continue this conversation related with the management of Hirschsprung disease. I suspect that Dr. De La Torre, my friend, asked me to talk about the anal canal in Hirschsprung disease because he perceived my obsessive ideas about the preservation of the anal canal in the operations for Hirschsprung disease. This obsession about the anal canal is a consequence of having witnessed many cases of patients with Hirschsprung disease who underwent an operation and that destroyed the anal canal. As a consequence, they suffer from fecal incontinence. In theory, patients with Hirschsprung disease are born with all the necessary elements to get bowel control. And therefore, there is no justification for these patients to suffer from incontinence if we perform a technically correct operation. So from the time of the description of Dr. Swenson about his procedure, he, most of the times, I think he preserved the anal canal. but did not put enough emphasis in his description of the operation about the anal canal from my point of view. Looking at the photographs and having witnessed an operation done by Suave, I don't think Dr. Suave mentioned the anal canal in the repair. And as a consequence, many surgeons who follow the principles of Dr. Suave perform operations that included the damage of the anal canal. In the case of Duhamel, he doesn't describe much, he doesn't talk much about the anal canal, but the characteristics of his technique, by definition, preserves most of the anal canal. And that explains why patients subjected to the Duhamel operation don't suffer from fecal incontinence, but rather from severe constipation, sometimes overflow pseudoincontinence. With the description of the transanal repair of Hirschsprung disease by Dr. De La Torre, I suspected that first of all, I love that technique, but it worried me that many surgeons perhaps will not be able to do the operation correctly, and the children will suffer the risk of a damaged anal canal. In this very primitive diagram, I just want to describe a few things about the characteristics of this structure, anal canal. This is the rectum, and this is the rectum, and this is the anal canal. All this from here to here is called anal canal. And it turns out that this particular area, the anal canal, is the most sensitive part of our body. Interestingly, we can feel the difference, we can discriminate the difference between gas, solid, and liquid. We cannot do that with our hands. We cannot do that with any other way. But in the anal canal, we can differentiate one thing from the other. So it's extremely sensitive. So if we manage to damage this area, the patient will have no sensation. May preserve something called proprioception that is considered a consequence of a distension of the muscle structure surrounding the rectum, but will lose the exquisite sensation that we have when we have a normal anal canal. In addition, surrounding the anal canal is a skeletal muscle, the sphincter mechanism in this patient. And therefore, if the surgeon managed to damage not only the anal canal, but also the muscle surrounding, then the patient would be absolutely hopeless in terms of bowel control. It is very important for us to remember that our rectum, our rectosigmoid, is our natural reservoir that is extremely important for bowel control. If not so much for bowel control, it's very important to make us social individuals, because our colon moves constantly, and the right colon moves faster than the left colon. And as we approach into the sigmoid and the rectum doesn't move and remains quiet most of the time. That means there is a reservoir that is catching the stool for 24 hours and doesn't contract. But then, for mechanisms that we don't know, every 24 hours or every 48 hours, depending on the habits of the person, the rectum starts contracting, indicating that wants to empty, and is pushing that fecal matter down into the anal canal. And then we feel that something is coming here, and then we realize that we have to defecate. That's when we voluntarily order our muscles to contract and hold the stool until we have an available toilet. Then we relax, and we have to wait until the next episode of peristalsis to empty completely. And when that happens, we empty completely the entire rectum. And And then for the next 24 hours, we don't have to use the toilet. And that's a great advantage for humans to be social. So that's why when we resect the rectal sigmoid, like we do in Hirschsprung disease, we are by definition introducing a big change in the normal physiology of defecation in the human being. If we remove the rectal sigmoid in me or any of you, the consequence of and preserving the anal canal, the consequence is going to be that we'll feel the urgency to use the toilet very often because we don't have reservoir. So in other words, a portion of the colon from above that is constantly moving will be trying to pass the stool. And there is no reservoir, so you will feel the desire to go. And we have to re-educate ourselves before the stool. So if you look at a patient with a colostomy, you will see how the colon works. For instance, you see the stool coming out constantly, whereas because there is not a reservoir, it's normal colon. And the more proximal the colostomy, the more active is the passing of stool. So when we operate a patient for Hirschsprung disease under the best circumstances, preserving the anal canal, we are introducing a big change that an adult may adapt himself to the big change, but a little child may have difficulty in managing that situation. And that's why some patients, many patients, young kids, to whom we remove the rectal sigmoid, they have sometimes having problems trying to control the stool. But eventually they become educated, provided we preserve the anal canal. So I have been shocked by the number of patients that are subjected to an operation for Hirschsprung and suffer from fecal incontinence. And I must say it, we don't hear a lot about this problem in our meetings in the American Pediatric Surgical Association, in the American Academy of Pediatrics, in the European Association of Pediatric Surgery. People don't talk much about this. And I think it's a very serious problem. But most important is something that is preventable. So any technique that you use, what laparoscopic, non-laparoscopic, transanal, any technique that you use, the surgeon must keep in mind that must preserve the anal canal from this area right here down must remain intact. And that's why the different surgeons describe that they like to do start the resection about 1 centimeter from the pectinate line. Well, if you start even a little higher, it's even better. Because if you say you started the dissection 1 centimeter above the pectinate line, with all the surgical maneuvers and their difficult exposure, at the end you realize that you invaded part of the anal canal. And that's why I personally prefer to start the dissection 2 centimeters above the pectinate line, to be sure that we want to be absolutely sure that we don't damage the anal canal. And it is not easy to do that, and it's not easy to do the anastomosis in that location. But if you do that, your patients should not have fecal incontinence. As I mentioned, little children may have a period of mild incontinence at the beginning, but if you preserve the anal canal, they will gain bowel control. Look at here a picture of a normal anus. We use this wonderful Lone Star retractor in order to see the anus and the anal canal. So all this is anal canal. All this is anal canal. And then we put this retractor like this, and then we put these hooks, this particular hook, we put it here, and this particular hook here, and this here, and this here. And by doing that, now we are going to be exposing only the rectal mucosa, not the anal canal. And we'll start our dissection 2 centimeters above that. In this side, you can see a patient that underwent an operation for Hirschsprung disease, but the surgeon resected the anal canal. And here you see that the rectal mucosa is anastomosed to the skin. You don't see pectinate line, you don't see anything here. You don't see crypts, you don't see anything. So this patient suffers from permanent fecal incontinence. Another case, you see In this particular case, this is skin, and this is rectal mucosa. The surgeon resected the anal canal, fecal incontinence. In another case, in addition, sometimes just by putting the patient under anesthesia, we see a patulous anus, an anus that doesn't close. And that tells you that in addition to the lack of anal canal, the sphincter mechanism was damaged. Here you see, in this patient, show only one part of the anus, without the beautiful retractor that I mentioned. You see pure rectal mucosa directly anastomosed to the skin, damaged anal canal. And sometimes we see a combination of damaged anal canal plus stricture. The stricture comes from lack of blood supply and tension of the anastomosis. Another case with similar problem. Another case. Well, so please try to preserve the anal canal as much as you can. That's the key part of an operation for Hirschsprung disease, regardless the surgical technique that you use. This is applicable to all techniques. Keep in mind that if you don't preserve the anal canal, your patients are going to have fecal incontinence, which is actually tragic. First thing that we do when we receive patients that were operated for Hirschsprung disease and suffer from incontinence is offer them an examination under anesthesia to see the status of the anal canal. Well, we have so many patients suffering from fecal incontinence that when the fecal incontinence is permanent, we offer them our bowel management consisting in the administration of enemas. It takes us 1 week to determine the specific enema that is good for every patient by trial and error. We don't believe in formulas by kilograms of weight, body weight, so forth. We have to try because every patient needs a different type, a different volume, a different type of enema. Once we determine that, then if we suspect or consider that the patient will need enemas for life and is getting into the age in which the patient starts complaining about the enemas, we offer the operation, the so-called Malone procedure, appendicostomy or neoappendicostomy when the patient have no appendix because the appendix was resected. Another thing that we want to recommend to all general pediatric surgeons, be careful. Don't just remove the appendix just for incidental reasons. So the appendix is very valuable, particularly in patients with anorectal malformations and Hirschsprung disease. So the Malone is a pediatric urologist from England that had the idea to anastomose the tip of the appendix to the skin in the right lower quadrant. That technique was changed and modified. We decided that it was better location, the umbilicus. And also we decided that it would be convenient to create a one-way valve mechanism between the cecum and the appendix by plicating the cecum around the appendix to avoid leakage of stool to the umbilicus. So a few details about the technique that I want to share with you. So this is about management, administration of enemas through the rectum in order to clean at least all the entire left colon and rectus sigmoid. And assuming that the colon is moving normally, which means slowly, the new stool that comes to the right colon, the new stool would take at least 24 hours to reach the rectus sigmoid. And those 24 hours, the patient is going to be completely clean. So when we modify, as I said, Malone came up with the idea of connecting the appendix to the right lower quadrant. We prefer to do it in the umbilicus for the patient to receive the enema sitting in the toilet and passing the catheter himself. The patient becoming independent. They love that. And then wait until the entire colon is clean and then remain clean for 24 hours, provided the motility of the colon is normal. How to placate the cecum around the appendix? Well, if you consider the appendix is an organ with a mesentery, here you see the appendix, and this is the mesentery of the appendix. So if you want to wrap the cecum around this appendix, you are compressing the blood supply of the appendix. If you create a very tight valve, it produces ischemia in the appendix. And therefore, I came up with the idea that I'm sharing with you. If you look at with the meticulous in the appendix, you see one vessel here, one vessel here, another vessel here, another one here, another one here, another one here. In between the vessels, there's an avascular area. With the needle tip cautery, I remove that tissue in between. And now you see the windows between the vessels of the appendix. And now you can wrap the cecum around the appendix, preserving the blood supply. You can wrap around these gaps without compressing the vessels of the appendix. Look at the way it looks. Here you see this is the appendix, this is the cecum, and you see this is a gap. This is one vessel of the appendix, another vessel of the appendix, another vessel, and another vessel. So the stitch goes taking the cecum here, takes a little bite of the appendix, and takes the cecum on the opposite side. You can tighten it very, very tight without compromising the blood supply because we are preserving the blood supply. That's a little trick. And it's useful not only for Malone procedures, but also for mitrophanol, because in the mitrophanol, you implant the appendix in the bladder, and you can do exactly the same. And it's a very valuable trick. And then how do we do it? How do we do the procedure in the umbilical to make it as invisible as possible? Well, here you see, here you see this is a triangle of skin created in the belly button. This is the belly button. This is the belly button. This is a midline incision, and this is the appendix. This is the appendix. So we make in the anti-mesenteric part of the appendix this incision. We spatulate the tip of the appendix, and then we make a triangular skin flap here in the deepest portion of the umbilicus. And this triangle of skin is going to be accommodated in this triangular space of the appendix. Let's see how we do it. This is the appendix. This is the triangle of the skin. And we start putting 6 cervical sutures taking at the edge of the appendix here to the edge of the skin. So, and then this edge of the skin is going to be sutured to this edge of the appendix. And it's supposed to look like this exactly. So the triangle of skin is now deep there. So this is the way we do it, the Malone procedure. More details about the technique. This is the triangle of skin, sutured. You don't see the sutures that are now hidden, and this is the appendix. There's more details. See, this is the one stitch in the tip of the appendix, another stitch in the tip of the appendix, a catheter, an embryo feeding tube in the appendix, the lumen of the appendix. This is the spatulated tip of the appendix. So one edge here, one edge here. And we are going to make a triangular skin flap here to accommodate here. Let's watch that. So now, this is one edge of the triangle. This is the other edge of the triangle. This is going to be the tip of the triangle, and this tip is going to be sutured deep in this angle here. And this edge of the skin is going to be sutured to this edge, and this edge to this side. There you see this is the tip of the triangle that's going to be sutured to this corner. There you see, and now we are going to suture this edge to this edge. We finished that part. And then we are going to suture this skin to this part, and this skin to this portion of the appendix. And by doing that, we finish the operation. Then we close the incision. This is after we plicated the cecum around it. That's the way our patients look at it. If it happens that the patient has no appendix, which is relatively common, then we learn to make appendices, and we make them sometimes more beautiful than the natural appendix, because our new appendix don't have mesentery. What we found made this as observation. The colon, this is not well shown here, but the colon has the blood supply of the colon, the mesentery of the colon, are vessels that come to this medial side of the colon. But they come and they divide into some vessels go posterior to the cecum, some vessels go anterior. So And those vessels run perpendicular to the main axis of the colon. This is one vessel perpendicular to the main axis, vessels perpendicular, and the same behind the colon. So we selected a flap, being sure that it has a nice vessel. Unfortunately, our medical illustrator didn't show a good vessel fit, but actually you can detect a very good vessel running in this direction. And therefore you can make the flap and guarantee that this part of the flap will preserve its blood supply. It's the only tissue that I know in our body that you can make a long flap with no mesentery and preserve the blood supply in the tip. But you have to detect, to select the area based on the presence of this vessel. And there you see, when you lift the flap up, the flap must preserve its blood supply beautiful all the way up to here if you follow the rule. See, remember, the vessels running perpendicular to the colon. This is the vessel, and the vessel, you don't see it here behind the flap. And then you just start closing. We close the colon in 2 layers of interrupted sutures, and then we close the appendix with 1 single layer of 6 cervical sutures, and that's the new appendix with good blood supply. But now we have to create the valve mechanism. For that, you can lay down this neo appendix in this part of the colon. And don't lay down this, putting sutures in front of sutures. If you lay down this in front of this, you are leaving sutures in front of sutures, and that's a mistake, technical mistake. Don't ever leave sutures in front of sutures, because it's an invitation for the creation of a fistula. So we lay down the appendix away from our suture of the colon. And we plicate the colon around the new appendix, and that's the end of the operation. And then we have to mobilize this cecum, we have to mobilize in order to do to anastomose the tip of the appendix to the umbilicus in the way that I already described. This is in vivo in a very dilated cecum, and then I decided to make the flap. This is the main vessel. You see the vessel, very nice vessel. And the flap is going to be like this, like this, like this, and like this. And the blood supply is going to be excellent in the tip of the new appendix. There you see it, the new appendix. And there you see it. Now I'm plicating the cecum around the ascending colon around the new appendix. That's the way it looks. Well, I try to share with you a couple of tricks that I found valuable in my practice. And all this is a consequence of long practice, including many errors. And I feel very happy to share that with all my colleagues together. So thank you very much.
For patients who suffer from fecal incontinence and require a daily enema to be artificially cleaned of stool in the underwear, an antegrade enema procedure is a good option to allow for independence during enema administration. In this video, we share our technique for appendicostomy, also known as Malone procedure. We start by creating a triangular flap in the umbilical. And we extend the incision down as a small midline laparotomy. Once the appendix has been identified, we create windows in the mesoappendix. The tip of the appendix is then opened, and a number 8 French feeding tube is inserted towards the cecum. The appendix is laid down on the cecum, away from the ileocecal valve, and we create a valve-like mechanism by wrapping the cecum around the appendix, taking a bite of the cecum, a small bite in the appendix, and another bite in the cecum with non-absorbable sutures. The mesoappendix windows allow for plication without compression of the appendiceal vessel. We then return the cecum to the abdominal cavity and start the anastomosis between the appendix and the umbilicus. The first stitch includes a deep stitch to bring the tip of the umbilicus down. The following stitch consists in anastomosing the edges of the triangle to the edge of the appendix. The distal appendix is trimmed off and the cecum is tagged to the abdominal wall. The umbilicus is reconstructed and the midline laparotomy is closed in layers.
Please type in the chat if you have any question or congratulations.
So I don't see any questions, Luis. I don't know why when Dr. Peña presents, there are no questions.
Because they are afraid.
Okay, there is a question. Do you have any experience with percutaneous cecostomy?
No, I have no experience with percutaneous cecostomy. That procedure is done by interventional radiologists. Here's the problem. They do the procedure, but they don't follow the patients. So the cecostomy is done percutaneously. Those patients, as you know, frequently come to the emergency room complaining of different types of problems. Sometimes they have rash in the skin around the cecostomy. Sometimes the cecostomy tube comes out and you have to replace it. Sometimes they leak around the cecostomy, and therefore they are frequent visitors to the emergency room. And they, in the emergency room, they don't call the interventional radiology, they call us. And that's why when I arrived to Children's Hospital, I said, I have nothing against those colostomies done in interventional radiology suite, but I will not follow those patients. I only follow the patients that I do. So if somebody wants to perform operations, that person that's a universal, must be a universal rule. If anybody wants to do an operation, that person must take full responsibility for the follow-up and long-term follow-up of those patients. The easy part is the procedure. These are patients for life. If you do a Mitrofanol or a Malone, you have a patient for life that will come for different reasons to look for you, and you must be there. So we are morally obligated to follow our patients.
So we have a little more questions. How long do you leave the tube in the appendix? 1 month.
So we leave the feeding tube for a month, and after a month, the patients come to the clinic, and we change the feeding tube and show the parents and show the patient how to do it, and he leaves the clinic with no catheter. Once the patient learns how to pass the catheter, that he can go without the catheter. But many times we tell the families to keep the feeding tube for a month, but the tube comes out because somebody pulled it or whatever, and then sometimes we access the Malone orifice earlier than 1 month.
There's another question. What's your indication of appendicostomy in Hirschsprung's disease?
The indication would be fecal incontinence, that the patient prefers the enemas administered through the umbilicus rather than through the rectum.
There's another question. When you have a small appendix, do you suture the cecum to the parietal peritoneum to avoid traction?
So when we didn't mention that in the technique of the Malone procedure, actually we fix the cecum to the anterior abdominal wall around the umbilicus to avoid traction in our suture. You see, the suture of the appendix to the umbilicus are very delicate sutures, and that's why we don't want any traction. And yes, we fix the cecum around the umbilicus to avoid that traction.
When can I start the irrigation of the colon after a Malone?
If you perform a Malone procedure, you can start the irrigation right away, anytime. If you perform a neoappendicostomy, remember you have a very long suture line in the colon. That's why we don't like to give enemas to the catheter for 1 month in neoappendicostomy.
Do you think that suturing the appendix to the triangular skin flap help prevent stenosis, or is just cosmetic reason?
Both. I think it prevents strictures and is for cosmetic reason, both.
In older patients, post inadequate pull-through, no stricture, dentate line preserved, and still having constipation, what would be your threshold for suggesting a Malone?
So first of all, constipation is not an indication for a Malone. So the constipation is treated with laxatives. And I think Dr. De La Torre already discussed a lot about the problems of constipation and stool retention and enterocolitis in patients for Hirschsprung. The one thing that I would like to add in dealing with constipation and Hirschsprung is that besides the fact that some surgeons put through an aganglionic segment, perhaps in addition to all the cases that develop a stricture in the anastomosis. I think Dr. De La Torre already mentioned that. And also the theories, because there's a theories of lack of relaxation of the sphincter, of the internal sphincter, about that. And they are that on symptoms. Characteristic of Hirschsprung disease is that spastic narrow distal colon and a very dilated proximal colon. More dilated, the older the patient. That's why in developing countries, we see patients with a giant colon. So my recommendation is during the operation for Hirschsprung, resect the aganglionosis segment and resect as much as you can the dilated part of the colon. We have scientific and clinical evidence that a very dilated hollow viscous doesn't work well. In other words, for the peristalsis to work adequately, you need certain diameter in the lumen. So if you dilate, the peristalsis is no longer effective. And therefore, my routine is remove not only the aganglionic, but the most dilated part of the colon, because if you leave it, the patient will have constipation, even if with no stricture, even with normal ganglionic. So that's an advice.
There is a question if we have used coiled tube, shaped tube in appendicostomies. So I'm going to answer this one. The reason why we do Malone in appendicostomies is trying to avoid having a permanent tube. But there are some patients, for example, that are developmentally delayed, or they do not accept the parents catheterizing every day. And for those patients, yes, we ask interventional radiology to place a shaped tube. How do you solve problems with the length of the appendix in obese patients?
That's a very, very important question. Unfortunately, obesity, one of the reasons why we become pediatric surgeons is because we don't like to deal with obesity. Is not the pediatric population. That's tragic, I think. And that's your protocol developed countries. And it's happening as we are talking. So if I see a patient with severe obesity, I said, go lose weight and then come back. I don't operate on you.
There's another question. How, if you need to close the Malone, how do you do it?
If you only close it, some patients, occasionally we see a patient that is using the Malone and then he doesn't need the Malone anymore. In other words, the Malone was done because the patient suffered from fecal incontinence, and then suddenly when he grows up, he manages with diet and routines and discipline to have spontaneous bowel movements at a predictable times, and then he decides he doesn't need the Malone anymore. So you just pull the catheter and leave the orifice there, it doesn't bother him. Sometimes they come back and they say, well, it's leaking stool, or it's leaking mucus, or I don't like it. Then it's very simple, just make just ligate the connection of the appendix to the skin. You don't have to remove the appendix, you just ligate it and that's it.
Another very good question. Have you ever had an intestinal obstruction due to internal hernia in cases where you have had the umbilical Malone procedure?
Yes, we had that. And it's concerning because I don't know how to prevent that. We have several cases like that. And
the fixation of the cecum.
Yes, hopefully the fact that we fix the cecum to the anterior abdominal wall helps to prevent that, but it happens. And I cannot comment anymore. If you have any answer for that, that would be great. But I don't know how to prevent that.
There is a question in Zoom, Alberto, that there are, yeah, the question is for you, but they said there is a group of colorectal surgeons in the United States that they are promoting and recommending the use of appendicostomy in patients with post-operative colitis, to treat post-operative colitis. They want to hear from you.
I have no experience with that. We don't take care. I don't take care of patients with inflammatory bowel disease, including Crohn's and ulcerative colitis.
No, enterocolitis. They are doing Malone's for enterocolitis.
I'm sorry, enterocolitis. For
Yes.
Hirschsprung and oh, absolutely not. I would not do that. Let me explain. That's a very good question because hard to believe, but in major institutions, many providers don't know the difference between enema and irrigation. Patients with motility disorders such as Hirschsprung disease, basically having incapacity to have effect, they don't have an effective peristalsis, and therefore, by definition, enemas are contraindicated. Irrigation means passing a tube through the rectum and to allow the liquid stool to come out through the lumen of the tube. So you just by passing the tube into the rectum and to the colon, must be a big tube, so the liquid stool comes out immediately. So irrigations are not useful in solid stool. When the patient gets solid stool, the patient needs enema. Now, enterocolitis means liquid stool, and those patients need irrigation. You pass a catheter and decompress the colon. If you try to do that through the Malone, you pass the little catheter to put liquid inside the colon, and you are distending the colon, and you are not helping the patient to empty. What the patient needs is a mechanism to empty the colon. You don't want to give enemas to these patients. This is very important because many patients come to our clinic with enterocolitis, and they come from important institutions. And they said we said, have your child had irrigations? And they said yes, but they don't work. And then we said, how do you do the irrigations? And actually, what they have been doing is enemas, not irrigations. So be aware of the fact that patients with enterocolitis need irrigation, no enemas. And Malone procedure was designed to give enemas. That's why we don't use that.
Thank you very much, Dr. Peña. Now we need to continue with the program. So the next conference is about constipation versus Hirschsprung disease. Now, let's talk about idiopathic constipation versus Hirschsprung. This is very important because some patients with idiopathic constipation receive, unfortunately, full truth or operation like Hirschsprung disease. And patients with Hirschsprung are diagnosed late, very late, because they were treated like idiopathic constipation. Remember, constipation is a symptom. It's only a manifestation of something that is happening with the motility of the large bowel. So constipation occurs when bowel movement becomes less frequent and the stools become difficult to pass. And this is just a symptom that can be produced by many problems. Completely different is Hirschsprung disease. Hirschsprung disease is a birth defect, is a congenital problem, as you know, in which the nerve cells are missing at the end of the child's bowel and in the rectum. And it does not work well in this portion. So it produces a blockage, an obstruction, a functional obstruction in the bowel. It's a localized obstruction. So there are two completely different problems, but because both share the problems to have bowel movement, this overlaps this symptom. Constipation is present in patients with imperforate anus. If the patient has good sphincters and a perineal fistula, vestibular fistula, or no fistula, it's not common to have constipation. So constipation is also related with patients that born or were born with an anorectal malformation. And that's why is this confusion, how to treat the constipation if the patient born with an anorectal malformation or with Hirschsprung or idiopathic constipation. Patients with Hirschsprung, they have constipation, many of them, and they require a different treatment. So one of the most common etiologies of constipation is the idiopathic constipation, this one. When a normal colon, as you can see in the middle of the screen, has a normal rectum, the constipation is mild. You can give whatever you want, and the patient is going to be fine. Don't confuse. When you have a small rectum, most probably the patient has Hirschsprung. But when the rectum is huge, is big, is dilated, most probably this patient suffers chronic constipation and then becomes a complicated idiopathic constipation with mega-rectum and fecal incontinence. So constipation just means less frequent bowel movement and is related with, again, anorectal malformation, Hirschsprung, and idiopathic constipation. The most common constipation is related with the idiopathic constipation. Share these symptoms, but we need to offer different treatments based on the origin of the problem. This conference is focused on idiopathic constipation, how to avoid problems in patients with idiopathic constipation, and do not delay the diagnosis of Hirschsprung. So when you have to think about Hirschsprung as a cause of this constipation, well, the patient has colitis, the patient is sick, has fever, is vomiting, bilious vomiting, no bowel movement, or explosive bowel movement when you introduce suppository or you do a digital exam. The patient does not have involuntary bowel movements, no fecal incontinence, no soiling, no incompressive. The patient with Hirschsprung do not produce hard, big, dry feces. If you do an enema, the patient becomes worse because it has an obstruction. Usually, if you do a good physical exam and a good history, you will see that the patient starts very early in life, usually when they're born, the first weeks of life. And the abdominal X-ray shows significant dilated intestines, all the bowels, usually most the colon. And the rectum, this is the most important in the contrastennum, is not dilated. When you have to think in idiopathic constipation, well, the patient does not have colitis, is not sick, is crying, complains of painful bowel movements, presents involuntary bowel movement, the patient has accidents, more common if you use PEG, and so it produces fecal incontinence or pseudo-fecal incontinence or incompressive, whatever you want to call. The patient has hard, big feces, painful bowel movement, has good response to enemas, and start usually after 3 or 6 months of age, usually. And the abdominal X-ray shows significant fecal loss, different from dilation of the bowel in patient with Hirschsprung. In patient with Hirschsprung, you will see the colon very dilated. In patient with idiopathic constipation, you will see a lot of stool. The problem is that very few primary care physicians pediatrician, general surgeon, general doctors, they do not request an X-ray in a patient with constipation. And if you request a contrast enema, the big difference is that the rectum is big, is dilated. Could be mild, moderate, or severe, or gigantic rectum. That's the difference between idiopathic constipation and Hirschsprung disease. So once the constipation is established, the rectum keeps the stool for more than 24 hours and produce big hard poops, painful bowel movement, and the patient cries and is on a crisis because the patient is having severe problems to obtain a bowel movement because it's really painful. If you give softeners, the most common is polyethylene glycol. This is going to produce liquid stool and the patient is going to have involuntary bowel movement. And you can read in the literature like incompressive. And this is a complication. A patient with constipation, we need to avoid to have these fecal accidents. And the other complication is if it's not treated properly and timely, the rectum starts to stretch and grow. And then it's going to be big, super big, and gigantic. And then is a big problem. So these are the two most common complications of the idiopathic constipation. This picture represents what I said. This patient is crossing his legs because he don't want to have a bowel movement. He's crying, he's complaining of abdominal pain, but he's having this kind of stool. This is the polyethylene glycol. This is the powder that you can give a patient with constipation. But if the patient has hard stool impacted, causing obstruction in the rectum, the patient is going to have this accident. So you can see the diapers and the patient is having accidents. This is the most common problem, fecal accident, and it's a complication. And the second one, again, you can have a big rectum, a super big rectum signal, and a rectum that moves the bladder to the left and is reaching the diaphragm. So this could be a mild, moderate, severe, and gigantic mega-rectum. And the cause, most common cause of this complication is an inadequate medical treatment. A medical problem that is fixed, is manageable with good medical treatment. If you don't do a good medical treatment, then the patient is going to have these two complications. So why it's happening? Why we have this, look, this gigantic bowel? When this bowel is in this condition, now it's going to have many problems with motility. And this segment is not going to have contractions. It's not going to have effective contractions. And you can give a lot of laxative and the patient is going to have many problems. Now imagine that the white areas, which is the contrast, is the polyethylene glycol. So this liquid is going to pass around this hard bottom stool and the patient is going to have accident. This is what happens when you prescribe this situation. And then, again, gigantic mega-rectal segment. If you want to treat this patient like a Hirschsprung patient, you will have many complications. If you want to do a manometry, to rule out Hirschsprung disease in this gigantic rectum, there is no balloon to fill this big rectum. So it's not indicated when you have this gigantic rectum to do a manometry. So idiopathic constipation is, again, like in biology, an spectrum. On the left side, we have mild constipation with no dilated rectum, no fecal impaction, just the patient complains that he's having painful bowel movement. And you can give orange juice, green juice, diet, fruits, and sometimes osmotic laxative could help the patient to have a more happy bowel movements. And the patient does not have soiling and no social problems. In the other side, we have the patient with chronic idiopathic constipation, fecal impaction. This obstruction is frequent and sometimes is chronic for weeks, months, and even years. If you want to give a diet or special foods, it's not going to help. This patient needs a stimulant laxative based on senna for many years. This patient, if you give polyethylene glycol, these patients are going to have fecal soiling, fecal incontinence. And then they will have important social problems and the mega-rectum signal that then becomes another problem. So what is pseudo fake Hirschsprung? Well, it's when a patient with idiopathic constipation and ganglion cells in the rectum is submitted to a surgical procedure for Hirschsprung. For example, a patient that you are treating with constipation and you give 1 cup or 10 milligrams or 17 milligrams or grams of polyethylene glycol, and the patient is not having good response. So you increase the amount of this medication, and again and again. And then the family becomes stressed. It's a situation that make a lot of stress between the patient, the family, the doctor, and someone decides to do a test to rule out Hirschsprung disease. Could be a contrast enema, could be a biopsy, or could be a manometry. So why are there cases of pseudo Hirschsprung? Why we have these cases? One is, again, because the patient with idiopathic constipation do not respond to the regular treatment. We don't know what is a regular treatment. Regular treatment could be just change in diet or just give more fiber with polyethylene glycol. We don't know what is a regular treatment. Then, because out of the desperation to find the cause of constipation, the physician orders a study that then is a false positive for Hirschsprung. And then, due to an error in the performance or interpretation of this procedure. So if you send the patient to make a manometry, because you want to see how is the rectal anal high inhibitory reflex, in this diagram you can see how the balloon is inflated and then the pressure in the anal canal is low. And this is absent. If you obtain this trace in the manometry, it's because the patient possible has Hirschsprung. But if you do not have this relaxation because you don't have a super big balloon to inflate and fill out these super big rectums, you are not going to have the rectal anal inhibitory reflex, and then you will erroneously assume or diagnose Hirschsprung disease. And this is one of the problems. So this is a trap and error. So this is the balloon, and you inflate the balloon. And the max capacity of the balloon could be 20, 80, whatever you want. But we have rectums that you can inflate the balloon and never you are going to obtain the relaxation of the anal canal. So be aware of this situation. Imagine that you have this patient and you want to inflate a balloon to produce the anorectal reflex. You are not going to have any. However, if you send this patient to radiology, a very enthusiastic radiologist probably is going to say, oh, okay, this is a Hirschsprung patient, because you can see here like an achalasia, and then they wrote the report has ultra short and sometimes short Hirschsprung. And then the family is stressed because they read the report. You never will see a patient with Hirschsprung with this anatomy, never. So when you send a patient for a contrast enema with constipation, and you see this image, oh my God, this patient has for many, many years this constipation, and is not Hirschsprung, even when the radiologist described like a short, a possible Hirschsprung, or rule out Hirschsprung or suspicion of Hirschsprung. Another error in this patient, a patient with constipation that is not responding to the regular treatment. Somebody said, okay, let's take a biopsy. And the biopsy became very superficial, just the mucosa. There is no ganglion cells. The consequence is the pathologist is going to report no ganglion cells in the rectal biopsy. And the patient is going to be submitted to a pull through. This is a pseudo Hirschsprung. Be aware of this situation. Now, another error trap. You take a nice biopsy. So you include the blue area, which is the mucosa, the green area with enough amount of submucosa. And you can see here the ganglion cells in the submucosa. But they just make very few sections. So in 2-3 sections of this biopsy, the pathologist, they don't see ganglion cells. And the report is biopsy of the rectum with no ganglion cells. And the patient is going to have a surgery for Hirschsprung. Another error. I want to show you this image. This patient has 16 years now, and she developed idiopathic constipation. She was managed with ethylene glycol for many years and lactulose, and she developed fecal incontinence and Mega-rectum. And then the contrast enema shows an image that was reported as ultra short Hirschsprung. For the surgeon, it was very easy to say, oh, we need just to resect a very small segment of rectum. And then you can see the complications. The patient has many operations. Now she needs an stoma, the perineum and the pelvis is freeze, a lot of fibrosis, and every month she needs to have a colostomy bag to collect her menstruation every month. This is a dramatic case that you need to keep in mind when you have a patient with constipation. Because if you do an operation for Hirschsprung in a patient with idiopathic constipation, probably you will have these complications. So there are two different groups of problems. One is idiopathic constipation and the other one is Hirschsprung disease. This is the perineum of a patient that suffer from idiopathic constipation. And now you can see the severe diaper rash in this image, secondary not to fecal incontinence, secondary to a structure. And this structure is producing leakage, constant leakage. This is after we have to do stoma and to treat locally with stoma powder. So idiopathic constipation usually start at this age. When the patient is little, the patient has 3, 4, 6, 8 months of age, and the family wants to potty train the patient when they are 2 years. So when they come to your clinic asking for help, here he's saying, doctor, I need help because I cannot have a bowel movement, or I have hard bowel movement, or painful bowel movement. And you are not aggressive to obtain an X-ray and then give a good laxative and then take another X-ray to corroborate, to prove that the laxative is working. And then you need to follow the patient. If you don't do that aggressive treatment, then the patient is going to be like this, with a huge, massive rectum. This patient does not have Hirschsprung. The patient is a patient with idiopathic constipation with a huge rectum, because for many years was treated with medications and treatment that were not successful. This illustration is something that I want to share with you. This is the feces in this huge rectal bowel. You can see this big reservoir not having contraction. It's a baggy bag. This is the anus with good sphincters. And the poop is hard, big, and dry. And look for how many years, many days are there. So when you have a patient with constipation, you need to treat properly. And do not do operations for Hirschsprung in patients with constipation. Thank you very much. And if you have any questions, I will be very happy to answer. When a patient with idiopathic constipation is having many problems, or even when it's well controlled with enemas or laxatives, in some point, and in some cases, a surgical treatment, unfortunately, is required. And I said unfortunately because idiopathic constipation should be a medical treatment. When we have to do an operation in this patient, we are really sad because that means for many years, something was doing wrong. In order to improve the quality of life of this patient, and with this philosophy to help this patient, is why we are doing some operations in these unfortunately kids. And sometimes they are not kids, they are adults, they are teenagers. This is an X-ray of a patient with idiopathic constipation. He's not a Hirschsprung patient. He was submitted even a biopsy of the rectum. The good news is that the pathology was very honest, and he said the biopsy was insufficient to do a diagnosis of Hirschsprung, so he had a second biopsy that shows ganglion cells. So the patient was sent to our center for a laxative trial. As you can see in this X-ray, there is a massive amount of feces, a lot of stool, hard stool even in the left colon, sigmoid,
and a massive fecal impaction in the rectum. What we do with this patient? And I want to explain this slide because this is the guidelines that we have for the management of idiopathic constipation. The step number 6 just happened in 4 to 5% of our patients. But remember that we receive patients with many years with idiopathic constipation, many years. We never have seen a patient with constipation with 2 weeks of hard-ball of stool or with 2 days with painful bowel movement. These patients usually are seen by the primary care physician, by the pediatrician, sometimes by the GI. We just receive referrals of patients with idiopathic constipation after many years of treatment. So our guidelines that could be applied for any patient with idiopathic constipation are these. Number 1, fecal disinfection or clean out of the rectum. So you need to have an X-ray like the previous one. And then you must do a complete clean out of all the stool in the rectum, sigmoid, and left colon. In order to do that, you need to start with rectal enemas. Sometimes we need to take the patient to the OR to do a fecal disinfection, a manual fecal disinfection. And some physicians use a combination of fecal disinfection in the OR, and at the same time, they place an NG to give an infusion of polyethylene glycol, like in this X-ray. In this X-ray, you can see here the NG already placed in the stomach because this patient is going to receive Prolapse or polyethylene glycol. We don't want to promote the use of NG because in patients with big rectums, the risk to have another fecal infection is very common, it's frequent. So the parent they need to do enema sometimes at home. They cannot place an NG and then give the infusion of polyethylene glycol. That's why we don't like, that's one of the reasons that we don't like. The second reason is that sometimes the NG and the PEG infusion just produce a huge distension of the bowel, and the patient starts to have some stool, and then the polyethylene glycol, and then a yellow liquid, and everybody believes that it's clean. If you take an X-ray, that is another common error, not to take an X-ray after an infusion of polyethylene glycol, you can see a lot of water and a lot of food, usually. Then, once the patient is completely clean, the most beautiful X-ray, no poop in the colon, then we can start this laxative trial. To start the laxative trial, sometimes we spend 3 days, sometimes a week, sometimes months. Once we start the laxative trial, we use stimulant laxatives. The stimulant laxative that we use is Senna-based. So this medication is a natural medication that is inactive and is going to be active just in the colon. And then, if we are to have successful treatment, we have daily bowel movements and no accidents, and the X-ray is clean after the bowel movement, we continue the Senna probably for months, years, or all the life. If the laxative trial is not successful, then the patient is going to need
daily rectal enemas. And there is a different combination of the rectal enema. But we always use saline to produce the volume, and glycerin and castile soap to produce the irritation of the bowel, and then to produce the bowel movement. The step number 4 is the long-term follow-up. Because if the patient, you have a successful laxative trial and a successful bowel management with rectal enema, even though you need to have regular follow-up with these patients, because the risk of fecal impaction is frequent. So we educate our patients and our families that if in case they don't have a bowel movement in 24 hours, or they start to have painful bowel movements again, or they have fecal accident, they have involuntary bowel movements, that means the patient has fecal impaction. And we need an X-ray, and then we go back to the step number 1 with rectal enemas, and then we continue with the step 2 or 3, depending on the patient. The step number 5 is almost a dream, because usually the parents always, the most frequent question is, for how long my daughter, my son, my kid is going to take Senna? The answer is, we don't know, probably forever. When we are going to start to decrease the amount of Senna, the frequency of the enema, we don't know. But we always offer this option to the parents. You want to stop the Senna, you want to stop the enemas, you want to start to winning the amount of laxative, we can do that. So we start very slow, because we know already that the risk of fecal impaction is high. So we start very slow, and we have frequent failures. So the successful on the step 5 is almost 0 in this patient. And that is the cause, is why is the step number 6. Because now imagine a patient that is taking 20 tablets of Senna every day, 15 tablets of Senna every day, an enema every day for the last 10 years. In some point they say, there is another option. I don't want to have more enema per rectum. I don't want to spend more money buying Senna. Because if you multiply 10 squares of Senna per month, 300. Now, per year, more than 3,000 tablets. Now, if the patient is taking Senna for 1 year, 2 years, 3 years, the parents are upset, and the patient. So that's why the surgeons try to help these patients, but should be very selective patients. There are many operations that have been attempted to help these patients, but just few have good or acceptable results. The AC procedure, the resections, or the creation of enteroscopy. Before the patient goes to a surgery, we do a bowel management long week. Long week because we start usually Wednesday or Thursday with the contrast enema. Then on Friday, we give a workshop to give education to the patient and the family. Then we do the evaluation in clinic, and during the weekend, the patient starts to practice the bowel management. And Monday, Tuesday, Wednesday, Thursday, the patient, we adjust the enema, or we adjust the amount of Senna with X-ray every day to control these patients, and a very clear description of the bowel movement.
So we have discussion every day of the patients, and then we do phone calls or telehealth and sometimes clinic with these patients to adjust and explain the change in this week. And the last Friday, we discussed the final plan for the future in every patient. This is how we do the step number 2 and the step number 3. We don't know, because always the question is, why the patient with idiopathic constipation produce this huge mega-rectum? We don't know. But we are sure that many patients born with a normal colon, with a normal rectum, with a normal signal, these natural reservoirs, if they start to accumulate chronically, feces, for some reason, start to stretch and enlarge and then become a mega-rectal signal. So this normal contrast enema in a patient with 2 days of constipation, if you don't treat the patient properly, over the months and years, they develop these huge mega-rectal signals. There are different procedures described in the literature, so you can consult these revisions in the literature. The references are here below. Myectomies, myotomies, Botox, anal dilation, enterostomy, punctures, resection, colectomy, subcolectomy, different types of ACEs, even in the left colon. But the results reported with these different surgical procedures are completely different from group to group. Some report bad results, some report no good results, and this is very confusing. You need to read these reports to understand what I want to say. We don't have time to discuss these papers, but it's the reality. In the desperation to do something, we have seen patients with 10 myectomies, patients with more than 10 injections of Botox, patients with appendicostomies and this patient never had before a rectal enema, so we don't know if he's going to have good response to an enema. Anyway, this is one of the lists, but this could be large. What we do in our center is partial resections, the creation of AC procedures, appendicostomy or neo-appendicostomy, when the patient is having very good response to the enema. AC, as you know, means antegrade continent enema. If you do a cecostomy, and the cecostomy is leaking, is passing gas through the device, because the cecostomy requires a device, is not a continent procedure. And AC means continent because we don't want to have the patients having bowel movement through the appendicostomy or cecostomy. You already know what is an appendicostomy because Dr. Bishop talked about this procedure. So the appendicostomy, just to remember, is to create a valve in the base of the appendix, place the tip of the appendix in the bottom, and then place the catheter to give the end. The neo-appendicostomy is to create a flap, then tubularize this flap, and then place this conduit in the abdomen of the patient, usually in the belly button. This is a patient with an appendicostomy, now with the catheters, and that's it. We use the appendicostomy in patients that
have very good response to enema, and they don't have good response with laxatives, or they don't want to use laxatives. They refuse the use of medication. And the only way to do a daily cleanup of the colon is with enema. So over the years, they request an AC procedure. The sigmoidectomy, the resection of the intra-abdominal dilated portion of this mega-rectum sigmoid is the sigmoidectomy. The sigmoidectomy requires a resection at the level of the peritoneal reflection. Then to mobilize the left colon to this portion of the pelvis, in the very, very high portion of the pelvis. So you need to close partially the rectum, which is very dilated, and then do an end-to-end anastomosis in this portion. These diagrams are from the publication of Dr. Peña in 1993. Remember one thing, and this is very important in patients with idiopathic constipation. The rectum starts to have problems, and then the problem becomes more proximal and more proximal and more proximal, and then it's a huge problem. So even when you resect the sigmoid, we have to left the rectum, which is sick. And I want to say is the most sick portion of this segment. So this normal in caliber, in diameter bowel is going to fight with this portion that has been sick for many years. So in these x-rays, you can see the pre-operative contrast enema and the post-operative contrast enema. This contrast enema was taken 3 months after the operation. So in this, on the left side, you can see the mega-rectum and the mega-sigmoid, and the patient was submitted to a sigmoidectomy. So now the patient only have this mega-rectum, no mega-sigmoid. Some patients have very good response to this operation, and they are very happy. We can decrease the amount of Senna from 15 tablets to 1 or 2. Sometimes the volume of the enema is very low compared with the previous, before the operation. But one of the main complaints that some patients have is left colicky pain. We don't know why. We assume that this colon is having huge contraction to overpass this functional obstruction in the rectum. So if you do a sigmoidectomy, this is the patient before the operation. This is the sigmoid. You can see the stool here in the rectum. Now we contrast. And this is the post-operative control. So the problem is still in the rectum. And that's why many patients after this operation, they are not very happy because they have fecal impaction. So we add an AC procedure. So we do the resection of this problem. This is a huge mega-rectum sigmoid. We cut here, and then we create the appendicostal. So this is another option. But again, this is the problem. Fecal impaction and colicky pain in the left side in some patients. This is the final aspect in this diagram of this operation. Sigmoidectomy plus AC. Again, mega-rectum sigmoid, and now just the mega-rectum. And that's why in this video you can see how the contrast is one to pass through this mega-rectum. This is the anastomosis, and you will see how the contrast is back and forth, and the feces are floating in this segment. The rectum is a baggy bag, is not having any contraction. So you can see the contraction in the small bowel, even in the large bowel, so the rectum is not having any contraction. So, in some point, a group of colorectal surgeons decide to do a complete resection of the rectum and the sigmoid, like a Hirschsprung patient, a transanal proctosigmoidectomy. And this is the picture of the publication. And the results of this operation is that the patient, they don't have any more constipation. They cure the constipation. The problem is that most of these patients now have fecal incontinence with very active colons. So they need enemas and Loperamide. So we came with a different idea. Instead to resect all the rectum, we left 5 centimeters like a minimal pouch, a very small rectal pouch. So we place a long star retractor. We measure 5 centimeters. Then we prolapse this portion. And then we cut around these traction sutures. And in a full thickness dissection, we resect the rectum and the most proximal part of the sigmoid. And then we have to leave the skin, the anoderm, the anal canal, and 5 centimeters of rectum. Look the difference in the diameter. And then the anastomosis. To do the anastomosis, you need to place a stitch at 12, 3, 6, and 9 in both in the distal dilated segment and in the not dilated proximal segment. And then many stitches right here. And this is the only portion that we left in the rectum. This is the preoperative contrast enema, and this is the rectal size after the operation. And you can compare it here. This is the mega-rectum sigmoid, the sigmoidectomy. You need to do the resection in the peritoneal reflection, and you have to left all the rectum in situ. And in the transanal resection, you need to resect all the rectum and the sigmoid. In the transanal proximal rectosigmoidectomy, you need to leave 5 centimeters. In this group, this patient preserved the fecal control, which is lost in this operation. So, cons and risks. We have to leave the complete rectum, and the natural reservoir is very easy to have a fecal impaction. Abdominal pain, the left side, and obstructive symptoms again. If you do a transanal complete proctosigmoidectomy, the reservoir is lost, and the patient has fecal impaction. Patients with this operation usually are very well, I want to say most of them, and the most important, they preserve fecal control. When we do a resection and AC, or when we do just a resection, well, if we have a patient with a mega-rectum sigmoid and the patient have any neurological problem like autism or whatever, we do an AC. If the patient is a complete normal patient without any neurological disorder, the patient just needs a resection, because most of these patients are very good with a very small amount of laxative. Even we have patients after a proximal proctosigmoidectomy having daily bowel movement, good fecal control, and no medication. Thank you very much, and we have time for questions. Okay, thank you very much, everyone. If you have any question, please type in the chat.
So I see one about dietary modification. If it does impact your population, and if you have been able to win patients of a bowel management program with strict and intense diet modification.
So remember, the population that we, the population that is referred to our center are patients with many years with constipation. Even though we recommend always to have discipline with the food, with the meals. We never give a list of different food or the special diet, like a laxative diet, the patient. What we do with the regarding the meal is we always recommend to have 3 meals and no snack. Also, if the parents already detect or the patient, they know that some food produce more constipation, we recommend to stop this food. There are some patients that the same food produce a laxative effect. And in another patient, the same food is going to produce constipation. There are many ideas that we have in the center to explain the parents how to change the food. We have some few experience in patients with constipation that they have a vegan diet. And the vegan diet is, in some patients, is very useful. So we don't have the experience with this diet. We have patients in the spinal bifida clinic that they change the diet for the regular diet for a vegan diet, and that helps a lot to these patients to resolve part of the constipation.
Yeah, I just want to emphasize what Luis said, that diet modification is something very hard. And if you have children, you know how hard it is. Just to give them regular diets. So I think we have to be conscious about that too. I think they're asking if you do a protective stoma to protect the anastomosis when you do surgery for idiopathic constipation, Luis.
No, we do not do stomas. We have only one case that had a leakage after the anastomosis. Unfortunately, this patient had a leakage and we have to create an ileostomy and then wait 6 months to close the ileostomy. In the other patient, we do not create a protective colossus. This is not a very easy operation. This is not a very reproducible operation, but is what we have for now in this very sick patient.
There's another question. Why not to do a transanal pull-through for the treatment of megasigmoid the same way you do in Hirschsprung? Fecal incontinence does not occur after transanal and the rectal pull-through in Hirschsprung disease. So why should it be a case with megasigmoid?
So I think they are talking about endorectal, like a swab. I think so. So if we try to do a swab operation, kind of swab, endorectal means that you need to do a mucosectomy. In my opinion, I never have done a mucosectomy to treat patients with idiopathic constipation. Why? Because what we have found in the histopathological report when we review this specimen is that the muscle is already has a lot of damage. The muscle has fibrosis. The muscle is broken, like I want to say something like when you stretch something and then it's broken, and in between the muscle fibers, there is a lot of fibrosis. So my concern to leave muscular cuff in patients with idiopathic constipation is because it's going to produce it's going to produce obstruction again. So my idea was to resect in a full thickness, like a Swenson, leaving a small rectum, because we need a natural reservoir. Even 5 centimeters has been enough to prevent fecal incontinence.
So I think the question was for the cases, for the paper that you present when Dr. Peña was doing the resection, it was full thickness, and fecal incontinence did not happen in every patient. The majority did not have. But if you think that patients with constipation have a very dilated rectal sigmoid, in order to dissect that, you end up stretching too much the anus, and that's what we suspect was the cause of fecal incontinence in the few patients that had it. Those were not our patients, but they were in the series. There's another question, Dr. De La Torre. A constipated boy, 12 years old, with constipation since he was 3 months old, suffers from pseudo-incontinence, and GI insists on making a biopsy to rule out Hirschsprung. He has normal growing, never had enterocolitis, colostogram with mega-rectum sigmoid. How do you proceed?
Okay, so we explained very clear in the video what we do with this case. This is, thank you very much, Macarena, for this question, because this is the everyday question. This happened everywhere in all the country. When a patient with idiopathic constipation does not have good results with a regular treatment for constipation, which usually and unfortunately in the world, the polyethylene glycol is a pandemic problem. Usually these patients start to have more mega-rectum, more pseudofecal incontinence, and in the desperation, the anxiety that produced this unsuccessful treatment, many GIs and many pediatricians start to think in Hirschsprung disease. So if this patient is going to have a biopsy, you need to be sure, Macarena, that the biopsy is going to be done perfect with good submucosa. If you can take a full thickness biopsy, perfect. And then you need to have the best pathology to confirm that this patient, this 12 years old patient, has ganglion cells. And then everybody's going to be very happy because now is not a Hirschsprung patient. But the problem is when in this 12 years old with constipation, the biopsy is done not properly, I mean, superficial, or the pathology, they don't have experience, and they said, I don't see ganglion cells, probably it's a Hirschsprung, then this poor patient is going to have a surgery for Hirschsprung. This is what I call pseudo-Hirschsprung. And the most terrible problems that we treat in the center are patients with idiopathic constipation treated like Hirschsprung. So be careful about that. We do not do biopsies in these patients.
There's another question, Luis. When do you start feeding the patients after the operation?
We are very conservative and we do a super good bowel prep. We place a central line a peripheral central line, a thick line, and then we keep the patient NPO 7 days with PPM. Let me tell you how frequent we are doing this operation. In this year, we have done only 3 operations, and we have hundreds of patients with constipation. So it's not a common operation.
Another question is if you can use the circular stapler instead of the transanal anastomosis.
No, I do not recommend to use a stapler because the stapler produce a very narrow anastomosis. I want to tell you a very recent case. It was a patient with this problem, idiopathic constipation and severe mega-rectum sigmoid, and he was submitted to a sigmoidectomy, and he had an anastomosis using a stapler. And then the patient started to have severe obstructive problems. So we have to pass a catheter through a transanastomotic catheter, a Foley catheter, to help the patient to be decompressed. So we don't use staplers in this operation.
And there is another question. What is the ideal patient for the transanal proctosigmoidectomy? And there is more questions on Zoom.
Again, I don't like to do this operation. I don't want to do this operation. There is no ideal patient, never, for constipation. Nobody wants to do operation in patients with these gigantic, these monsters in rectum and sigmoid. But when the patient is taking a lot of laxatives for months or years, and they don't want any more laxatives, patients that they have more than, you cannot believe how many injections of Botox, the number of admissions to the hospital for fecalis infarction and God likely infusion, and enemas every day, and they have a recurrent fecal infarction, is when we try to help this patient with a different treatment. But all the patients are submitted to our protocol of fecal for constipation that we already showed you. So there is no ideal patient for this operation. It's just I want to say, the last resort that we have in these patients.
There is one question in Zoom asking if you can share your results after the transanal proximal rectal sigmoidectomy. Were you able to stop the SENA?
Yeah. The results after the resection?
Yes, and if patients were able to stop SENA.
Yeah, you can read the report. It was already published in the Journal of Pediatric Surgery, and you can see the results, and you can see how the amount of SENA was decreased, and at least 3 patients, they are not taking any medication. I mean, no laxatives, no enemas. They are doing very well. Just 3 patients in this cohort of patients. You can read this in the Journal of Pediatric Surgery.
There's a question, what's your opinion about the posterior strip myectomy for constipation?
I never have done this operation, and I think it's like I think is something like a myectomy. But I don't know. I don't have experience with that.
And the last question, what complications can be expected after the transanal rectal sigmoidectomy?
I think that the complication that you can have in this operation is leakage. If you are not sure that your anastomosis was done very well, you need to create an stoma to protect the anastomosis. So it's a good idea to do an ileostomy for 3, 4, 5 weeks after this operation, and then you can come back to the OR to close the ileostomy to prevent leakage. There is a question in Zoom about the Refeeding. I don't know if everyone is familiar with the Refeeding technique, which is very popular in Europe. Yes, if you want to do a Refeeding operation, it's very similar to the sigmoidectomy described by Dr. Peña many years ago in patients with pseudo-fecal incontinence and anorectal malformation. So the idea of Refeeding was to left between 6 and 10 centimeters of aganglionic bowel. So it's very similar to the sigmoidectomy. So you can try, it's a good idea to do a Refeeding operation in patients with idiopathic constipation, and we can compare Dr. Later. It's a good idea.
I think that was all, Luis.
Okay. So, Ray, we continue with the next conference. So the next conference is about the transanal approach for after episode. Thank you very much. We're very happy. We're very happy having you in this course. We know it is virtual with live discussion. We hope that this health problem affecting all the countries could be resolved very soon, and we can have in-person meetings to have very fun time, happy time, and discuss many things that we can do with our colorectal patients. Thank you again for being here with us. This is my last presentation in this Hirschsprung course. And the title is Transanal Approach for Hirschsprung, for idiopathic rectal prolapse, and for the rectal prolapse produced after the repair of an anorectal malformation. Again, thank you very much, all of you. We miss you all, we love you all, and we hope to see you very, very soon. In 1996, in the Universidad Nacional Autónoma de México, the main university in Mexico and Latin America, we did experimental study or practice to learn laparoscopy in rabbits. This was approved by the ethical commission in this university, and we started to do endorectal punctures in rabbits. These rabbits weigh between 3 and 4 kilos, so it's almost like a newborn. And this old image taken many, many years ago. You can see here the rabbit with the ports.
then the instrument that we use to dissect the vascular supply in the colon, and then how we did the mucosectomy of the rectum in this beautiful animal. So what happened when we were doing this operation in rabbits? We realized that we were able to mobilize only with a transanal approach, with no abdominal approach, a good length of bowel in the rabbit. Why? Because the rabbit, the colon of the rabbit does not have attachment. They don't have the left colon and the right colon like that, like we have the attachment. So in 1996, came to the Instituto Nacional de Pediatría a patient with Hirschsprung. As you can see here, how we use our rectal tube, the NG tube, we did the irrigations, and finally, we decided to start this operation just with a transanal approach. The contrast shows a rectosigmoid Hirschsprung, and it was very successful. The patient started to eat very soon, 2 days after the operation. He started to have bowel movement. And anyway, he had very good outcome. And we were very, very happy. And then this is the same patient. Some years later, 6 years after the pull-through. And this is the first transanal endorectal pull-through performed in the world in October 1996. And then with my colleague, my partner, my friend, and Dr. Jose Arturo Ortega, this great surgeon, we published the technique in 1998. This is me. You cannot believe it, but this is me. Some years ago in the Instituto Nacional de Pediatría. So this approach for Hirschsprung is beautiful. Isn't very, very nice when you have a very good transition zone in segment affecting the rectum and the distal segment. And that happened in probably 60 to 70% of the patients. And this is the picture that we have to show how we mobilize the colon in these patients. I want to show you this movie. The first part is for a suave. We start doing dilations. This is the Lone Star hooks placed in the skin. So this is the anal canal. Then we replace the hooks, replace in a more proximal way to protect and cover all the anal canal. So as you can see here, this is just rectum. There is no anal canal. The anal canal is hidden by the hooks. This is a 5-0 silk suture. So we place this suture to traction. This is just for demonstration to show you the anal canal. Again, this is the traction suture, and we are going to remove the hook. The anal canal is here, right there. This is rectum, okay? Probably 5, 6, 7 millimeters. So we start with a electrocautery, doing cutting around the stitch, very close to the stitch, because we need to preserve some rectum. Then we cut the submucosa, and then we found the muscle. Once we found the muscle of the rectum, we do like in the open operation, we do a blunt dissection. It's important to keep traction. My finger is behind. With traction, look how it's stretched the mucosa, so you can see the circular fibers of the rectum, which is the inner layer, mucosa, and then the muscular is these circular fibers. When the muscle is floppy, is really loose, you can place stitches taking mucosa and muscle, and then cut in between, and then you are going to be inside the abdominal peritoneal cavity. So you now can see the serosa of the proximal sigmoid. You need to cut all the circumference. This is the muscular cuff, the proximal colon, and then we ligate after the dissection of this vessel. You can ligate proximal and distal, and then cut, and you will start to gain length. You need to do the ligation of these vessels in the lateral wall, left and right, and then in the posterior wall. Left, right, and then the posterior. And you are going to have more and more and more and more length of this. Let's see the full thickness. The full thickness is the same. When we start, we protect the anal canal, and then we start the dissection with the electrocautery, retraction sutures, and then we test the wall with this lacrimal probe. So you need to identify the wide fascia that is attached to the rectum. This is the fascia. So we are cutting the fascia. It's the same fascia that you cut and dissect during the pull-through in patients with anorectal malformation. The same band. Imagine that you need to obtain more length with an anorectal malformation. It's the same concept. So this is the dissection of the rectal fascia in a slow motion. And the same, once you reach the peritoneal reflection, you need to open it, and then you are going to be in the peritoneal cavity. And again, the same. Sutures, left, right, and then posterior. And you are going to obtain length of this bowel. If you have a ligature, like a Maryland ligature, you can use. This is the dilated portion. In both cases, in the Suave and the Swenson, we took a full thickness biopsy for the intraoperative study and confirmed that we have ganglion cells. Deep cut, we need to look and observe the mucosa. You see the mucosa, this is the biopsy. And we close the incision of the biopsy in two layers. The first is we run and lock the suture with trio silk suture, and the second layer, lumbar suture. In both cases, whatever you do, Suave or Swenson. And then when we have ganglion cells, we do a 2 layers anastomosis. So the first layer is taking the ceromuscular to the cuff or the perirectal tissue, depending on what technique you want to do. And then we cut the colon and we send to pathology the circumference
This is the donut. Dona in Espanol, donut. And then we finish the anastomosis doing the colorectal anastomosis. If you do a coloanal anastomosis, the patient is going to be fecal incontinent. Remember, don't forget. Okay, so you can see here, right here, this is the anal canal, and the anastomosis rectal, rectum, and colon. And then we remove the retraction. You can see in my YouTube channel many of these videos. This is my YouTube channel. You can look these videos unedited, so you can see step by step this procedure. This is the transanal approach for Hirschsprung, Suave or Swenson. It is important to keep in mind to preserve the area of the anal canal. The anastomosis should be done here. If you do the anastomosis in the anal canal, fecal incontinence, don't forget. This is the most important area. So you can take a picture, don't forget. Unfortunately, the transanal approach has been very popular. I am really sad about this situation because now everybody wants to do transanal approach for many things. And this novel approach, as you can see in the literature, to avoid abdominal wall incision in children with long segment intestinal aganglionosis. So the patient has a huge port that allows to place many ports at the same time. I'm wondering how is doing this patient, if he has fecal control or not. So the transanal approach should be performed with care as any other operation. It's a delicate operation. We need to protect the anal canal. We don't have to stretch the sphincter. And is the history of the surgery. Duhamel complains about Swenson because Duhamel probably was not good doing Swenson. Suave complains of Duhamel, probably because Suave was not good doing Swenson or Duhamel. And now there are papers complaining of the transanal approach. Probably the surgeons are not good doing the transanal approach. So that's why we have a big menu to do safe operations. This is the view in an open operation. In the Suave procedure, this is the fascia. This is the muscular cuff in the Suave open and the prolapse. Many of you probably never have done an open Suave or an open Swenson. So this view, it is very important to learn because now the view is this one, the Suave transanal and the Swenson transanal. And this is the view. We do not prolapse the rectum. That's why we need to protect this area. So we need to replace these hooks more proximal in this point, this one at this point, this one at this point, and then you need to start the operation. The rectal prolapse, the idiopathic rectal prolapse, is a common problem in some group of patients. And there are many techniques, you know, probably more than one. Why? Because we don't have the perfect technique to repair the rectal prolapse. Many years ago, more than 100 years ago, a military physician created a technique for rectal prolapse
in the elderly patient when they have prolapse in the 70 and 80 years old. So he created a technique to doing the application of the muscular cuff. He did a mucosectomy, and this surgeon last name is Malone. So we start to do the Malone with some modifications. I want to show you how we do it. We place the Lone Star, then we replace the hooks again to protect the inner canal. And then 1 centimeter, we start to place many traction sutures. So you need to place one here at noon, at the 12, 3, 6, and 9, and then in between many. And then 1 centimeter, we do the resection of the mucosa. So again, we cut just the mucosa, and with blunt dissection, this is the muscular cuff in this patient with prolapse. This is the mucosa. And this cuff is going to be plicated. So you need to put many sutures. We place suture at 12, 3, 6, and 9, and then in between. So in and out, all the length of this muscular cuff. And this is the end of the application. Okay? So we left this muscular cuff. And then we're going to cut the mucosa here and then do the anastomosis with the rectum. This is the proximal colon. This is the rectum, each at 12, 9, 6, then 3, and then in between many. We finish the anastomosis. Then we remove the Lone Star, and voila, the prolapse is not anymore. The recurrence is the question. How many patients we have with this operation? Currently, we have more than 60 patients, probably 62 or 63. And we have 2 recurrences, both in patients with myelomeningocele. This is experience with our operation. You can read the technique in this publication from 2019. The name is Transanal and Rectal Approach for the treatment of idiopathic rectal prolapse in children experienced with the modified Malone procedure. This is collaborative paper with the Colorectal Center in Puebla and the Colorectal Center in the Instituto Nacional de Pediatría. Using this approach, using this operation for the idiopathic rectal prolapse, then we start to have patients with the prolapse after episode. Usually patients with bad anatomy, patients with rectal bladder fistula, prostatic fistula, cloacas with a common channel 4, 5, 6 centimeters, patient with a full sacrum. Anyway, so after you do a episode, some patients have prolapse. And there are 2 techniques described. One is doing a flap to repair the prolapse. So you need to create 2 flaps. And the other is to do a new anoplasty, doing resecting doing the resection of the prolapse and then do a new anoplasty described by Dr. Alberto Peña. The recurrence of these 2 techniques are reported from 10 to 60%. So we decided to start to do a mucosectomy in these patients and do the application of this tiny muscle of these patients. So this is a patient, you can see the scar of the PSAR. This is the posterior surgical incision. You can see the patient has bad anatomy. This is the prolapse. So what we do is to preserve the original anocutaneous junction. So we do not detach the anoplasty. So you can see here the line that is the mucosa with the skin. So we left like 3-4 millimeters of mucosa, and we placed many traction sutures around the mucosa of this prolapse. So this is the original anoplasty, the letter B, the C is the skin, the A is the mucosa of the prolapse. We left this edge like 5-6 millimeters, many traction sutures, again, same procedure. We cut all the circumference and do the mucosectomy for 5, 6, 7 centimeters, sometimes 8 centimeters. And you can see here the muscular layer of the rectum that was used for the pull-through in this patient with anorectal morphology. Now, in this diagram, you can see the skin. This is the original anoplasty, the mucocutaneous junction. This is the mucosa that we left for the anastomosis. This is the muscle of the rectum used for the PSAR, the mucosectomy. So you can see here 8 centimeters in this diagram. Now we are going to place the stitch here to do the plication of this area. So this portion now is going to be close to this portion. This is the suture, in, out, in, out, in, out. And we place again at all the circumference. We start at 12, 3, 6, 9. And then when you tie, you will see how the muscle is plicated. And then it's very close. So now we're going to cut here and we are going to do the anastomosis right there. And the original anoplasty is here. So the patient does not have any suture outside and do not require any anorectal dilation because it's a colorectal anastomosis. So this is the pre-op image of this patient, and this is the post image of the patient. We have done, at the moment, 40 operation of this procedure. We have, again, 2 recurrent in patients with very bad anatomy. We are very happy with our results. And again, this is my last conference. We hope to see you soon in this amazing children's hospital located in Aurora, Colorado, in the medical ancient campus. This is the children's hospital, the frontal view. We work here, very happy, with many dreams to help many patients with colorectal and urogenital problems. Thank you very much. And if you have any questions, we will have time to answer. Okay, so if you have any questions, please type in the chat. I just see one question about if we do this primary, like a primary treatment. I'm assuming that Dr. Manal is asking about the idiopathic rectal prolapse. Yes, when a patient has this idiopathic rectal prolapse, usually when they refer this patient to our center, is because they already have at least 1, 2, or 3 previous attempts with other medical or surgical treatment. And we do primary. We do not do colostomies in this patient. Thank you for the question, Dr. Manal.
So in 8 minutes, we will have the break. Dr. Javier Jimenez, what do you think about laparoscopic rectification in the idiopathic rectal prolapse? I think it's a good technique, Javier. You can do that. You need to use, usually when we do this operation, we use a mesh. We suture the mesh in the episacral area, and then we do the rectopexy to the mesh. With this new operation, with this modified Malone operation, we have not done any more laparoscopic rectopexy. Okay, yes, it was for idiopathic rectal prolapse. Thank you for clarifying this question. Macarena, is there any age when you start operating an idiopathic prolapse? Usually the patient with idiopathic prolapse is a patient in our group, I said, in pediatric. Usually the patient is over 3 years of age. It's very uncommon to see idiopathic rectal prolapse in patients younger than 3 years of age. Usually they are 4, 5, 6 years, and usually it's after a severe time of constipation. Thank you for the question, Macarena. We do mucosal rectal prolapse. No, I don't have this experience. I don't know if Andrea has experience with the question is if we do mucosal shading post-rectal prolapse in an rectal malformation. I think it's the technique that Alberto described. I think so. I don't know.
I don't know what mucosal shaving means. So I would say when the prolapse is mild or just in one side, I still just do the resection as we used to do. But when it's full thickness, I do the technique that Luis just presented.
Yeah, Dr. Amir Hussein Ladan. Yes, of course, you can use injection of dextrose 50. When we did the paper, we reviewed the literature and the techniques, and we found 53 different ways to treat rectal prolapse. That means there is no one effective treatment for the prolapse. 53 different papers with different treatments for the idiopathic rectal prolapse. This is very interesting. What if we don't do the application? Yes, probably if you don't do the application, probably you're going to have the same result. But, Dr. Jung, let me tell you, because after you do the mucosectomy, sometimes the perforating vessels that came from the adventitia in these patients have some bleeding. The deplications help to control this bleeding. So this is another reason that's why we do the application, to avoid bleeding and hematoma. No, we don't do dilations after these 2 last operations. We have not used dilation. If the anal sphincter is done in the transanal rectal tube, fecal emissions seem to be from the liver.
here for doing the operation if the vaginal colon was very wide. Okay, that's a comment. Thank you. No, there is no stenosis after the application of the muscular cup, Dr. Jimenez. Thank you for the question. I don't know if we have questions in Zoom. I don't have any.
I don't have any too.
Okay, so it's time to have a break. That's a very good question. Always the parents, when we present this technique in another conference, it's a common question. If the patient with anorectal malformation is fecal incontinent and has rectal prolapse, the repair of the rectal prolapse is not going to change the fecal incontinence. If the patient is constipated and we do this operation, the constipation is not going to change. And most important, if the patient has fecal control, this operation does not modify the fecal control. So we preserve the fecal control in patients that already have fecal control. This is a very good question. Thank you very much. Okay, so let's take a break and then we continue what I think is the most important. After you do colorectal surgeries, remember 50% of the patients with a colorectal problem will need bowel management. And the bowel management should be done by you, the surgeon, and your team. So after the break, we are going to talk about how we do, how we treat the patient with colitis and patients with fecal incontinence. The conference is going to be by Dr. Bishop, and the second one by our colorectal nurse, Amy Krause. So see you in 15 minutes, right?
Sounds good.
Okay, 15 minutes.
Hello, Ray. Let's start, please. Hello, everyone. I don't have camera, but we are going to continue with the next conference. The next conference is bowel management for colitis, enterocolitis, irrigation versus enema. And Dr. Bishop is going to present this conference.
Bowel management for colitis, which means rectal irrigation. I hope during this course you have realized the importance of having a technically correct pull-through, but the other important step is to know how to properly do a rectal irrigation. Unfortunately, there is a lot of confusion between rectal enemas and rectal irrigations, but they are not the same. So we use rectal enemas, meaning that we're going to infuse a large volume concentrated inside the patient, and we expect the patient to expel on its own. So we use it to clean the colon in patients that are fecally infected or in patients that are fecally incontinent, and we want to clean the colon so the patient stays artificially clean in the underwear. So for rectal enemas, we usually infuse in the patient between 200 mL or 800 mL of saline with some irritants, glycerin, castile soap, fleet, and again, the patient will expel on its own. We'll have a massive bowel movement after the enema. So here's how we typically do. We insert a Foley catheter, we inflate the balloon, we pull back to act as a tampon, and then we're gonna infuse that solution. We want the patient to hold the solution to dwell, so all the stool can dissolve, and he or she will have a massive bowel movement. That's the definition of an enema. So if you see this abdominal x-ray, this patient is fecally infected. This is a radiograph showing significant amount of solid stool. This patient will need several enemas to disinfect. So if we do a rectal irrigation, and I will explain what it is, in this patient, nothing will happen. So this patient does not need rectal irrigation. This patient needs enemas, a strong and concentrated enema. Now, rectal irrigations are used for a different purpose. We are trying to decompress the colon, and in this case, we have liquid stool and a lot of gas. So rectal irrigations are done in patients with Hirschsprung that are suffering from Hirschsprung-associated enterocolitis. So in this case, what we are gonna do is we're gonna insert the Foley, and through this Foley, we're gonna drain liquid stool and gas. We inject small amounts of saline solution, between 10 and 20 mL at a time. And all what we are doing with the saline solution is making sure that the lumen of this Foley catheter is not obstructed. So here you can see in a short animation of a rectal irrigation. We pass the Foley catheter, and through the lumen, we're gonna get this liquid stool and the gas to drain. And we will move the catheter so we can find pockets of liquid stool and gas. And as you can see, little pieces of stool can clog the Foley. So that's when we inject little amounts of saline solution to make sure the lumen is clear and that it continues to drain. So remember that in a patient with Hirschsprung, they have incapacity to empty. So if we do a large volume enema in a baby with a recent diagnosis of Hirschsprung, we're gonna make this patient worse. So what we need is to mechanically decompress the colon. And this is what rectal irrigation means. So here's an example of an abdominal radiograph before rectal irrigations and an abdominal radiograph, same patient after rectal irrigation. It's impressive how the patient immediately improves, feels better after a properly done rectal irrigation. So when we meet a family with Hirschsprung disease, the first thing we want to teach them is how to properly do a rectal irrigation. This is a life-saving maneuver for patients with Hirschsprung. I always tell the families, your other kids may have a GI bug, this child will have enterocolitis. Your other kids may get a little cold, this child will have enterocolitis. And when you're in doubt, you do a rectal irrigation. You're never going to harm a patient by doing a rectal irrigation. So here's another example. You can see here the characteristic image of what we call enterocolitis. The patient has a very distended colon filled with gas and liquid stool. And after we do the rectal irrigation, you can see a completely different image. Patient is feeling much better. Another example, here you can see the colon filled with gas. We do a rectal irrigation and we see a completely different image. So for the rectal irrigation, there's no limit on how much saline solution you're gonna use. So for example, I had a baby that came to me 1 year of age. When he came, the abdominal x-ray was so concerning that the radiologist called me. And I looked at the patient, extremely distended, and I said, let's do a rectal irrigation. The patient was already operated for Hirschsprung, had a good operation, but didn't know how to do rectal irrigation. So on that day, I irrigate that patient with 4 liters of saline solution. Sorry, 2 liters of saline solution, but I got back 4 liters. So what we do is we insert the Foley, inject just little amounts to make sure the lumen is not obstructed and let the liquid stool drain. And when you're measuring how much you put in and how much you get out, you always need more out than what you're putting in. And once we have determined that this patient needs rectal irrigation, the patients will do it 3 times a day. So our protocol is after a patient is operated for Hirschsprung, the patient leaves the hospital doing 3 rectal irrigations for a month and flagell 3 times a day. On the 2nd month, we're going to reduce to 2 rectal irrigations and flagell 2 times a day. And in the last month, 1 irrigation a day, flagell 1 time a day. And by that time, hopefully the patient is already stooling spontaneously, which is a good sign that the patient may not need rectal irrigations. And every time the patient presents with enterocolitis, we're going to restart this protocol. I know it's hard, but once you explain to the families, even pre-operative, they will understand. And once they do the rectal irrigation properly, they know it does not hurt. The patient feels better. And when patients can verbalize, they even ask for a rectal irrigation when they are not feeling well. The good news is that I already mentioned, we restart the protocol each time the patient presents with enterocolitis. But the good news is that enterocolitis is still a little mysterious disease for us. We are unsure why 30% of the patients, even with a very well done pull-through, will have enterocolitis. But as they grow old, enterocolitis tends to disappear. We don't see teenagers with enterocolitis. So it's very important to explain to the parents pre-operatively so they know that enterocolitis may happen and they know that rectal irrigation is part of that child's life at least in the first few years of life. Thankfully, as they grow old, it doesn't continue to happen, provided you don't have other explanations for it. Of course, if you have an aganglionic pull-through, if you have a stricture, then it's a different condition. But if you have a very well done, technically correct pull-through, still enterocolitis can happen. And the best maneuver is rectal irrigations. I tell my families, if they're gonna go on a trip, they must take supplies for rectal irrigations in case it is needed. So now we're gonna watch an animation about how to do rectal irrigation. This animation is available in our website, and feel free to use with any family that you need to teach them how to properly do rectal irrigation.
Children born with Hirschsprung disease often suffer from enterocolitis. The best method for treating this condition is by flushing and emptying the colon with fluid, which is called rectal irrigation. You'll need the following supplies in order to perform a rectal irrigation: 2 small basins, a 60 milliliter syringe with catheter tip, and a silicone catheter. If your child is under 1 year old, a size 16 French Foley catheter should be used. And if your child is over 1 year old, then you'll need to use a size 24 French Foley catheter. You'll also need water-soluble lubricant and normal saline. Start by warming the normal saline. We recommend sitting the bottle in a sink of warm water, then testing the temperature of the saline on your wrist to make sure it isn't too hot. Pour the warm saline into a small basin, then draw up 10 to 20 milliliters using your catheter tip syringe. Position your child so they are laying on their back with their knees bent to their chest, or if they are bigger, with their knees bent with feet flat on a surface. Place the empty basin next to your child. Lubricate the top 2 inches of the tip of the catheter and insert it into the rectum. Gently push the catheter so it follows the curves of the colon. Insert the catheter approximately 4 to 6 inches. Pause for a moment to allow any stool or gas to drain out the catheter into the empty small basin. Connect the syringe to the catheter and inject the 10 to 20 milliliters of saline. Disconnect the syringe and let the saline and any stool drain into the empty basin. Advance the catheter about 1 inch and repeat the process until the discarded fluid is clear. Do not advance the catheter further than the wide divider port. It is important between each injection that fluid drains into the basin. If the amount of saline you inject into the rectum is more than the amount of fluid that returns to the basin, then there is extra fluid in the rectum. To drain the extra fluid, try moving the catheter in and out while twisting. If fluid still does not come out, then the catheter may be clogged. Pull out the catheter and flush with saline into the basin before reinserting. If you think there is still fluid in the colon, you can reattach the syringe to the catheter and very gently pull back on the syringe to draw out the fluid. Do not pull back on the syringe if you feel any resistance. It's important to record the amount of saline injected into the rectum and the amount of fluid that comes out. In a good rectal irrigation, the amount that comes out is larger than what went in. Once the drained fluid is clear, remove the catheter from the rectum and wash your supplies with soap and water, then set out to dry. The supplies are reusable. For more information, please reach out to the International Center for Colorectal and Urogenital Care.
Perfect. So I hope you enjoy this animation, and I hope you can dedicate and truly teach your families how to do rectal irrigation, because this is a very important portion of the care of Hirschsprung's disease. Thank you very much.
Hey, Kraus. I'm one of the nurses here at the International Center for Colorectal and Urogenital Care. Today, I'm going to be discussing our bowel management program for children that need enemas due to fecal incontinence, specifically in Hirschsprung's disease. I have no disclosures at this time. Fecal incontinence in Hirschsprung's disease is 100% preventable, 100% irreversible, and 100% irreparable. This is why it's so important for the surgical technique to be done correctly. In this picture, you see a surgery that was done well and the anal canal is intact. This child with Hirschsprung's disease will have full bowel control. In this next picture, you see that the anal canal is damaged. This child with Hirschsprung's disease will be fecally incontinent and need to be on enemas for life. This is where our bowel management program comes in to help patients all around the world be clean in their underwear. Our patients need to have a contrast enema before the bowel program starts, and I'll further talk about that in the next slide. Our bowel management program is offered once a month, and it starts on Friday. We have an education session that explains the importance of the program for each patient. The families then meet with us in clinic to evaluate and learn how to give an enema properly. A child with true fecal incontinence will need to be on enemas for life. When evaluating enemas this week, we will have the families give the enemas first thing in the morning and then get x-rays to evaluate how effective the enema cleans out the patient's colon. The family or the patient will send us daily reports if they're having stool accidents or any other issues for us to troubleshoot how to continue to help them. The daily information about the accidents, any problems, and then also the abdominal x-rays gives us the information that we need to help find the perfect enema recipe for each specific child. As you see here, this is what our week kind of looks like. It's laid out. Thursday, this is when patients, especially if they're from out of town, come into town and get the contrast enema. And then Friday, we have a workshop and they meet us in clinic. We do a thorough evaluation and we initiate the plan. So give them the specific enema recipe that we think will keep them clean for 24 hours. Saturday and Sunday is really the time that we want families to get comfortable giving the enemas, practice, kind of troubleshoot if there's any issues. Monday morning after they give the enema, they'll get an x-ray and send us a report. We then continue to discuss and evaluate the x-ray and then when the accidents happened, or hopefully the patient didn't have any accidents at all, and make changes throughout the week to the enema recipe. So that's what we do Monday, Tuesday, Wednesday, Thursday, Friday. Here is a picture of the contrast enema. And this is really important. It helps us find the right enema for each patient. The contrast enema, we fill the whole colon with contrast and then take pictures as the contrast is leaving the colon. This gives us a really good idea of the fill volume, so how much contrast could fill the whole entire colon. And this helps us decide how much normal saline, glycerin, and Castile soap to use during our enema procedures. It also shows if there's parts of the colon that are more narrow, and that would cause patients to have a hyperactive colon, or if there's parts of the colon that have been stretched out from chronic constipation, and this causes more of a slow colon. Here are two x-rays. As you see on the left-hand side, we have an x-ray that shows a lot of constipation. So if we got an x-ray like this after a patient had an enema, we would know that, number one, maybe they're not doing the technique right, and we'd need to have them come back into our clinic and review how to properly give an enema. Or possibly the enema solution that we are giving is not strong enough to completely clean out the colon. The x-ray on the right-hand side is a clean colon. And so this shows a completely clean colon. You see that there's no stool in there. And so if we have an x-ray like this after an enema has been given, we know that enema recipe is completely cleaning out their colon. If the patient is not having any accidents and any issues, we know that we're on the right track to finding the right recipe to keep this child clean for 24/7. So what is an enema? An enema is a procedure of introducing the liquid into the rectum via the anus. It has been around through many, many cultures and over thousands of years. It's an effective way to completely clean out the colon and prevent chronic constipation. So in our center, we use a 20 or 24 French Foley catheter, saline, normal saline, glycerin, Castile soap, fleet, lubricant, enema bag with a blower clip, and 30 cc syringe. And I'll go into more details about each of these and then also how to administer an enema. So first we have the Foley catheter. We either use a 20 French Foley catheter. This is if the child is under 1 year of age. If the child is above a year old, we will do a 24 French Foley catheter. It's really important. This Foley catheter has a balloon at the bottom, and this is what we use. I'll go into more details, but to create a plug in the anus. We have a feeding bag, and we use 1,000 ml bag, and this is where we put the enema recipe in. So the normal saline, the glycerin, the Castile soap, and sometimes fleet enemas. This is the 30 ml syringe, and this is used to blow up that little balloon at the bottom of the Foley catheter to create that plug. Lubricant is used for comfort. We put the lubricant on the Foley catheter before inserting it into the child's anus. The main supply that we use is normal saline. We use normal saline instead of water because the colon loves water. And so if you just put normal or put water into the colon, it will absorb out more readily than the normal saline that is the same concentration as our body will sit in the colon and be able to soften up the stool and do what it needs to help the stool evacuate from the colon. Our main supply that we use is glycerin to help irritate the colon and help evacuate all of the stool from the colon. Many times we will use Castile soap as well if the glycerin is not producing a good enough evacuation for that we want for the enema recipe. So the first step is we'll gather all the supplies for the enema. We have a 24 or 20 French Foley catheter, a 30 ml syringe, lubricant, enema bag, saline solution, glycerin, soap, and fleet. The fleet enemas we do use more sparingly, and it's not something we want to use with every enema that is given, especially if kids have issues with their kidneys. It can be harmful. Step 2, we prepare the enema solution as prescribed. So we'll pour the normal saline. We want this to be at body temperature. If it's too hot, it can hurt the colon. If it's too cold, it can cause cramping and discomfort. We have glycerin, soap, and fleet, and add all of those together. And then we fill the enema bag and prime the tubing. The fourth step is we attach the enema bag to the Foley catheter and then also attach the lunar lock syringe with 30 ml of water to the other side of the catheter. The fifth step is getting kids or older patients into positions that are comfortable for administering the enema. And this really is dependent on age. So if the kids are between 0 to 2 or 3, sometimes having them lay on the lap, on the parent's lap, and then having another parent be able to insert the Foley catheter is the best method. If they're a little older, school age, having them lay on like a little blanket. We just really want to do whatever is most comfortable. If they're older and able to be on their knees or on the left side, this helps utilize gravity to give the most effective enema. The next step is we put lubricant on the Foley catheter and insert it about 4 to 6 inches into the rectum. This should be done gently with care to avoid any discomfort during insertion. We then will inflate the balloon with 30 mL of air or water. We teach our patients to do water. It creates a better plug and seal with administering the enema. Once the balloon is blown up in the child's rectum, you will pull back on the Foley, and this creates resistance or like a plug so that we can administer the water or the normal saline, glycerin, the recipe into the child's colon. The next step is introducing the enema solution. So I always tell families to go about halfway up on the clamp and see how their child is doing, if they're having any discomfort or issues with the administration of the enema. They can slow it down. If the child's doing great with it and there's no issues, they can go all the way up. We do want to administer the whole enema in about 5 to 10 minutes. And like I said, you want to make sure it's at room temperature, and you can go slower if you need to, if it's causing any cramping or discomfort. Once all of the enema is in the child's colon, we will have what's called the dwell period, and basically you'll still be holding resistance, and you'll clamp down the enema bag, and all of the normal saline, glycerin, Castile soap will sit in the colon, and it will help kind of soften the stool and irritate the colon so that when we take the plug out, they get a good evacuation of that left side of the colon and the transverse side of the colon. So once you transfer your child or the adults transfer to the toilet, we will deflate the balloon and take out the water or air, and then gently pull out the catheter. Usually between 0 to 15 minutes, patients will have a good amount of stool that will evacuate from their colon. We do want them to sit on the toilet for 45 to 60 minutes to fully empty out their colon though. Here is a short animation of what the enema process looks like. So we insert the Foley catheter 4 to 6 inches, blow up that balloon, pull down to create the plug, have the solution go into the colon, have the patient sit on the toilet, and then over the next 45 minutes, they empty out all the stool from their left side and transverse part of their colon. And then the goal is for them to stay clean for 24 hours. So as you see, the stool moves into that left side of the colon, but they are not having any accidents. So many times with patients that have normal colons but have had damaged anal canals, finding just the right recipe for the enema can keep them clean for 24 hours. Patients with incontinence and hypermotility is more difficult because you need to slow down the colon to keep them clean for 24 hours. By doing this, we give them Imodium and then also a constipating diet. So here is a hyperactive colon without Imodium or a constipating diet. As you see, we do the normal administration of the enema, administer the recipe that's prescribed. The patient sits on the toilet and fully empties out that left side and transverse part of their colon. However, because the colon moves so quickly, after just a few hours, the stool is traveling through the left side of the colon and the patient does start having leakage. We don't think that it is practical to ask patients to do 2 or 3 enemas a day. And so our solution is to introduce Imodium and a constipating diet. As you see here, we administer the enema and we ask the patients to do Imodium 30 minutes before starting the enema process. We also ask patients to have more of a constipating diet to slow down the colon. Many times this is all we need to do to keep them clean for 24 hours. Sometimes we need to have them take Imodium 30 minutes before each meal. Every single time that we eat, it stimulates the colon to move faster. And so Imodium can be really, really helpful to keep that colon from staying slow so that patients can stay clean for 24 hours and have no leakage. The bowel management program is an amazing service that we have been able to bring to many patients around the world. It changes people's lives, and just knowing that with modern medicine, even children with fecal incontinence can stay clean and live and have the normal freedom to go to school, to have whatever job that they want, is just a really beautiful thing that our program has been able to bring to people. Here is one of our patients when he first came to the bowel management program, was still in diapers and, just felt not as comfortable and confident. And then at the end of our week, he had a big smile on his face, super happy in regular underwear and feeling very proud and ready to start school. If you have any questions about the bowel management program or administering the enemas, please feel free to ask afterwards. This is a really, really great program that we are able to have here at Children's Colorado, and we're grateful to be able to teach and tell people about it.
So I see one question: if we use the same technique for the enema when using peristeen, if we can still use glycerin or soap when we do peristeen. So I think most people are familiar with peristeen. Peristeen is a machine that we deliver the enema by pressure instead of by gravity like we do. The advantage of the peristeen is that you can do while sitting in the toilet. The disadvantage is that it's a single-use catheter and it's extremely expensive, at least here in the United States. So if the insurance company does not pay, it's very hard for a family to afford it. Yes, we still use the same recipe. The only problem is the peristeen machine requires that you fill the bag completely. So for example, if you want to do 500 mLs of saline and 30 of glycerin, you have to fill the bag with 1,000 of saline and 60 of glycerin, and then just inject half of the volume. But we still use the normal saline and the ingredients within the peristeen. Any other questions, Luis?
There is a question in Zoom that if you use the same protocol for rectal irrigations to prevent enterocolitis or to recover the patient in the post-operative time.
Yes. So we use this protocol to prevent enterocolitis. Enterocolitis is common post-operatively. So by starting this protocol, we avoid it from to happen.
And then if you use the antibiotic, oral antibiotic or IV antibiotic.
Okay. When we are using for the 3 months protocol that I showed, we use oral. Now, if the patient has chronic enterocolitis that every time we try to decrease the irrigation, the patient presents again, that's the one we're going to try to use flagyl intraluminal. So through with the irrigation, with the last irrigation of the day. So there's a question, what would you say would be the reason a patient previously doing great with a specific formula starts to need more time in the toilet to empty completely? So we want the whole bowel management process to be 1 hour. When we finish the week with all the families, bowel management is dynamic. Some patients stay with the same recipe for 20 years and never need to change. Others, from time to time, we need to change. So the first thing would be to get an X-ray after the enema to see if you're actually cleaning the colon, and to try to decrease the time, you increase the concentration. So you increase the glycerin. That's the most common scenario.
Dr. Jung, yes, we do the bowel management in a clinic base. We do not admit the patient for this bowel management treatment.
I think there are a lot of questions about the videos. All the lectures, all the videos will be available at the Hendren Project website. So if you are already a member, you know how to access. If you're not a member, you can send an email to ray@hendrenproject.org and request access. This is a website for physicians. So if you are a doctor, a nurse, feel free to request access. Another question, can enemas be used for life? Have you found out any adverse effect in the follow-up? Yes, enemas can be used for life. We have several thousands of patients using enemas for life. We have seen what we decided to call the narrow spastic colon. It's a publication in the Journal of Pediatric Surgery that we don't have a full explanation of why it happens. But other than that, we don't have negative effects. Do you periodically apply bowel decontamination treatment in cases of frequent enterocolitis? Whenever the patient presents with enterocolitis, I restart the protocol. It's a 3 months protocol, and it includes flagyl. Any other questions?
No, I don't see any other question. Somebody's typing. We have 1 more minute. Yeah, we don't have patients with neuronal intestinal dysplasia. So we don't use antibiotics in these patients because we don't have these patients here in the United States.
Well, thank you everybody for all of those that joined us.
Okay, thank you everyone. Have a wonderful day and weekend. Please stay safe. Of this world, we can see you soon in person in our next Hirschsprung disease course. Thank you very much. Anything else, Andrea?
I don't think so. It was a
Okay.
pleasure. We are here to help you in any way we can. And every month we have the International Colorectal Web Meeting. Feel free to join when we discuss cases.
Folks are the best for everyone. Thank you.
Bye-bye.